Good morning. This is Dr. John Bennett broadcasting from Miami, where it's 5:30 in the morning. We have today the honor of having Samer Hose, MD, an Iraqi neurosurgeon who just spent a month in Japan, and he's with a bunch of students, which is great. We have a couple of, he's going to talk about the literature behind cisternostomy. But first, let's meet the other neurosurgeons that are on the panel with us. Good morning, Juma.
Good morning, sir.
Could you tell us a little bit about yourself,
Hi,
please?
Samer. Yes, I'm Dr. Juma. I'm a neurosurgeon, young neurosurgeon, and I'm doing spine fellowship in India with the hope that in the future months I'll be doing neurovascular fellowship as well, probably with Professor Aip and Yuha.
Great.
I'm currently in India, BLK, New Delhi.
Very good. And we may be networking with Louis Borba. I don't know if you know Louis's name. He might come next. He might come in February. He's a big skull-based guy. Okay. Anyways, Rakesh, good morning.
It's good evening from India. It's 4 p.m. here. Hello everyone. It's my pleasure to be in this panel with Dr. Samir, Dr. Juma, and of course Dr. John. I'm Dr. Rakesh from India. I'm a neurosurgery resident. Thank you so much for inviting me for this lecture. Thank you.
Welcome, Rakesh. Okay, Samer, it's all yours.
Hi, John. Hi, everybody. Welcome, Rakesh. Actually, Rakesh, now we are real friends. And Juma, welcome, Juma. And it's good afternoon from Iraq now. And I'm Samer Hose, a neurosurgeon from Iraq. And I will talk about a conflicting topic about the cisternostomy, but it's not the usual cisternostomy. It's not the Professor Aip Cherian concept. He's the leader of the international project, but I will give my ideas after studying this topic and my intentions for future researches. I would like to present my colleagues who attend the lecture with us from Iraq. They are resident and medical student interested in neurosurgery or resident in neurosurgery. And I think they will contribute to discussion maybe. And after this lecture, we will continue offline for a lecture about statistics in neurosurgery. This will be not on the neurosurgical TV. It will be a local lab activity. So these are my colleagues, and maybe in discussion they will introduce themselves one by one. And I will start directly with I will screen share, John.
Okay.
And so,
yeah, good.
Actually, I'm honored to participate in this Super Sunday with such big names. And this is about surfing through cisternostomy paper. I use surfing because it's not only studying, it's to acquire idea and produce new thoughts or ideas. So my lecture objective will be in 3 parts. The first, a little bit, we'll talk about introduction to cisternostomy, what's the cisternostomy in reality, and illustrative case from Iraq, and finally, why me, who did this presentation and not Professor Aip. That's the objective. Starting with the cisternostomy, if you want to do cisternostomy properly, first of all, you should have knowledge about the CSF circulation. Actually, not in that way shown in the picture. You should know the CSF pathway in this classification or in this pattern, which is the linguistic classification of cistern into supra and infratent and all the detailed cistern, because these are your or will be your corridors. So that's the difference. You must study the cistern in that details. And a general idea about cisternostomy, I acquire a slide from Professor Ayeb's previous presentations. He's like the big ball, the pink ball is the brain, and the cistern is the blue just below, holding the brain. And this is the evil, where they're trying to increase the intracranial pressure. And what we try to do in cisternostomy is just to make a puncture in the cistern and to get the CSF out to decrease the intracranial pressure, or as they say, the intracerebral pressure, actually. That's the general idea. I think that's the most simple and direct illustration of what about cisternostomy. It's this view, and we will try to think out of the box. The cisternostomy in general, it contributes of 4 or 5 basic steps. The first of all is to sure you should open any craniotomy with access to the pterional region, and to start the first step as shown in the figure 1, which is to open the lateral orbitomeningeal band, which is a very important band for those knowing what's ROSI approach. So starting with the frontotemporal craniotomy, lateral orbitomeningeal band, and then we will go with the anterior craniotomy process. Opening the orbitomeningeal band will make this change in the illustration. Will open the frontal apart from the temporal. That's the advantage of this band. And then we get intradural, and the target is to go with the anterior craniotomy process, reaching the interoptic cistern, and first optical carotid cistern, then interoptic cistern, and that will be egress of CSF. And then after opening the optical carotid cistern and the lateral carotid cistern, the target will be the membrane of Liliequist or Liliequist membrane, which will, if you open it, you will get access to the prepontine and interpeduncular cistern. And there is a controversy about to use or not to use the posterior cranial process clinoidectomy if it's an obstacle. And that's the operative view. You will see the basilar tip. The cisternostomy guys tell us that their target will be the basilar tip. When they see the basilar tip, this is the end of cisternostomy. This is that means that the supratentorial CSF compartment will be connected with the infratentorial. That's the advantage. It's not just simple opening of cistern, it's connecting the supratent with the infratent. And this picture illustrates that, showing the basilar tip from pterional approach. So this is not very simple surgery, but it's promising. And the advice is to procedure. At this step, you should irrigate copiously with normal saline and put a drain. And usually they leave the drain for 5 days. And there is a separate article about this topic. And they say this drain will wash the lactate, tau, and the free radical, which will be as a secondary injury, to prevent secondary injury to the brain. So that's the general idea about cisternostomy. And now I'm not talking about what is cisternostomy. I'm trying to think of new ideas about cisternostomy, so should think out of the box. I will present first a case from Iraq. Actually, it's the only one that we did typical cisternostomy. There is a lot of trial here and here, but this is I think it's a typical use, and I respect the cisternostomy after this case because it's a life-saving step. It's not an operation. It's not a total procedure, just a step. We have a 3-year-old girl, victim of fall from height, 6 meters, presented with GCS score of 10, and with this brain CT scan, there is multiple bilateral fracture, actually it's a severe injury you can consider from the fracture, and there is a right frontoparietal subdural, and we go to surgery not because of this subdural collection only, not because of brain edema and midline shift, but because of open depressed fracture at the same location. So we decide to do surgery for this case. The surgery is a craniotomy for evacuation of subdural hematoma and the temporal depressed fracture. Then at the end of surgery and during hemostasis, there was a severe brain swelling with herniation of the brain from craniotomy side. Actually, it's a progressive herniation, maybe 2 cm above the bone edge. So we decide, at this step, we remove the bone and decide to change the procedure into decompressive craniotomy. But what we face is we cannot even close the skin because of the brain herniation. That means a lot of brain herniation. So at this step, we just decide to, let's try cisternostomy. And as the ventricular tap is not possible, already the ventricle compressed with the ICP, so we try cisternostomy and just elevate the front, a little traction on the frontal lobe, going to the olfactory, to the posterior end of olfactory cistern, then carotid cistern, and finally, when I see the chiasm and ACOM complex, we stop at this step, we get a wash, and it's a 3 or 4 minutes just urgent procedure, and the effect, we see the effect in 2 or 3 minutes. There will be a decrease in the brain swelling, and maybe in 10 minutes the brain is just calmed down, and we change the whole idea about the surgery, and we give the bone back, and actually we close in a very relaxed brain. There was a good egress of CSF and everything going smooth, just because we puncture 3 or 4 cistern and we get the CSF just from below the brain. That's a nice illustration that this is the post-operative, actually this is the post-operative CT scan showing the bony flap is lax over the convexity and without midline shift beta, and the brain is okay. And this is also post-operative but bone window scan showing the cistern. This is aerosol drops just reaching the cistern, demonstrate where we can reach. And I think the pneumocephalus is on the prepontine cistern just behind the posterior glenoid process. So this is the prepontine or interpeduncular. And we don't open it. So mostly it's incomplete Lilliquist membrane septation. Happily, the patient gained fully consciousness post-op in a dramatic way, and the CT is better, showing better signs, better edema, better shift, and the contusion is resolved. And even during follow-up, the patient is doing very well. That's the case that we just apply what we learn. I don't think it's a usual practice in Iraq, but we started. So keeping in that way, and that I give you a demonstration why we respect cisternostomy. It's not a simple procedure, it's a life-saving procedure. So after that, we decided to surfing through all the possible paper on cisternostomy, and actually you should include the video presentation of Professor Ayub. He presents cisternostomy, maybe more than 10 very nice lecture, different topics, and an effort to support the International Cisternostomy Project led by Professor Ayub Cherian. And he's a big supporter for this project, and even for us as a young generation, and getting advantage from being at a different place on the table to bring out of the book's idea to this project. That's the idea. I want to support the project, but not in their thoughts. I want to add our thoughts, combining brains together. I get the following impression. So what will I present now? It's a totally new slides, not in literature, not in books. It's our summation or our impression after reviewing the topic. The first idea, I think the evidence presented by this paper, they inject a material, one injection in the ventricle and the other in the cistern, and see what happened in the brain, which is connected to the inside of the brain more. And the slide is very interesting. On the left side is the result of ventricular injection. There is little material just getting inside the brain, but in the right side, it is the intracisternal injection. I think this is a real proof of what is what's cistern and what's the virtual open spaces, because this paper about virtual open spaces, which is the connection between the cistern and inside the brain. So my idea that this is nice presentation, but as an evidence, we need to do it on a human, because this is on mice. So we need to do that on a human in a laboratory way. I don't know how, in cadaver or whatever, but seeing such picture in a human will be the final proof of what's the virtual open space type 2 and what, because this will change the whole concept. Idea number 2 is, where is the cisternostomy in the treatment? If we have an intraoperative brain swelling, we should do CSF diversion either by EVD or LP, or decompressive craniectomy. Sometimes we need lobectomy. This is the usual stepwise ladder. Where is the position of cisternostomy? Where should I do cisternostomy? Should I do it in between, or it's part of the decompressive craniotomy? I should do decompressive plus cisternostomy, or no, cisternostomy is just a single step and I should compare it with the decompressive. That's my second question. We should work on this to prove it. And the third point, I try to get what's the types of cisternostomy, because I see many types in literature, and this is our proposed classification, that it's either from outflow corridor or inflow corridor. This means that either the cisternostomy is just to drain a fluid from the ventricle, or from cyst like ventriculostomy, or cystocisternostomy, which means arachnoid cyst maybe. And the other type, which is the inflow corridor, we open the cistern to get inside, not the opposite. It's two types. Either we do convexity, because the Sylvian is also cisternostomy, convexity or basal, and the basal should be supra and infratent. And I think this is the cisternostomy proper. That's the general idea. We should have a clear general idea about what we are doing. Actually, now in practice, when we say cisternostomy, they all talk about the basal cisternostomy, and mainly it's a supratentorial cisternostomy, just to connect it with the infratent. There is no infratentorial cisternostomy, convexity. It's not proved yet. So these are a general idea. We should fix the definition of cisternostomy then to get more advantage of the topic. Another new idea is what are the indication of cisternostomy? It's a common question. They say the trauma, or we usually do cisternostomy on skull-based surgery. So after literature review, we suggest the following. There is two types of cisternostomy, either planned or unplanned. If it's planned, either the vascular and skull-based microsurgery. This is a usual approach when we opening an aneurysm or tumor. We usually open the nearby system just to relax the brain, or in a traumatic brain injury, usually moderate to severe injury, not any type of injury. Always we need a lesion to evacuate subarachnoid, subdural contusion, or sometimes I think that's John. Okay, so
yeah, I'm sorry, okay.
These are about the planned cisternostomy. The unplanned cisternostomy is just, I give a demonstration case for it. It's an intraoperative brain swelling. It's unplanned. It's one of the choices that I should take it now. That's our view about the topic. I have maybe two more topics. The one about the recommendation. What we recommend. I know we are a beginner, but I'm talking about the general ideas. So I think the recommendation are for ICP monitoring guided trial, because the RCT trial usually failed, or there is a lot of patient loss with the RCT. So ICP monitoring guided trial, I think this is the idea. I need to see the ICP before and after cysternostomy, and that number will be the best evidence. Other points, cysternostomy deserve the book because it has its anatomy, its physiology, and its lesions. So, and its surgical approach. So it deserves a book, a separate book. And I suggest that surgical loop, I have intention to loop. So surgical loop as an alternative time-saving tool, because cysternostomy usually done with microscopy. In the very urgent cases with a lot of brain swelling, you need a lot of direction and retractions, maybe the surgical loop will be suffice for the procedure. And finally, as the Japanese way of Kaizen, to fight for the technique of cysternostomy, not the indication, because when you improve the technique, you will open more indication. That's my idea. I'm not, maybe this is not the same as Professor Ayep direction. He's a big supporter to the cysternostomy. I respect that, but my Japanese background give me now the idea that I should not fight for indication, that cysternostomy is better than decompressive or not. This is not my fight. My fight is to improve the procedure, and that improvement will open more indication. That's my final recommendation. And finally, there is a future direction of paper researches, maybe for us or for other. It's just a suggestions. And what are the critical cistern for cysternostomy? What cistern that I should, and what are the other options? And intercisternal, we know that between cistern there is a septum. Is it complete, incomplete? Where is the attachment of septum? So we need more like cadaveric anatomical studies about intercisternal septal anatomy. And foramen magnum valve, I said that the main target of cysternostomy to open the supratent to the infratent compartment, but we know that there is another valve not only at the tent but at the foramen magnum. Do we need cysternostomy around foramen magnum, cisterna magna, or whatever? And what are the indication? And I think, and if it's an angry brain, so we should do retraction. Sometimes we need cortical resection. I think better than denial the cortical resection during huge brain swelling, it's better to find what's the safest corridor to do it. I think this one of the directions. In the procedure, they say that we should put it drain for 5 days to wash toxins. I think this deserves another separate trial. What are the indication of a drain? Why I should always do always put a drain, and what are the best duration? If we get later a CT scan criteria indicating cysternostomy, that was the best, because I will prepare the microscope, the staff, all the following before according to the CT scan. It should be a CT scan criteria, not MRI, because usually we are talking about the urgent setting in a trauma. And what about bilateral cysternostomy? What about the cistern on the opposite side? Do we need it? Do we need to do it or not? What are the indication? And lumbar cistern, we know that the lumbar cistern, one of the largest cistern. What's its role? I opened the dura already above. Why I don't use the lumbar cistern or lumbar puncture easily? And to do or not to do laminotomy, because in cistern we usually reach the lamina terminalis and interoptic cistern, so it's not difficult to open the lamina terminalis to access the ventricle or to get egress of the fluid from the ventricle. I think this is very important point, because when the brain is just compressed and the ventricle compressed, the only pathway to get inside the ventricle is to see the lamina terminalis, because it will be the same, and I can evacuate the ventricle and decrease the pressure inside the ventricle from the lamina terminalis. So should I include it or not as part of cysternostomy? And finally, minimally invasive endoscopic cysternostomy, because when we do cysternostomy for arachnoid cyst, usually now the trend is endoscopic. So we can use it when and why. That's the general idea, and it's the finish of presentation. I will stop the screen share. Yes, John. I'm ready for any question. I'm honored that Professor Ayub and Professor Yoha Hernesini is there. And hi, Slavin. I'm ready for any discussion.
Hi.
You're welcome to ask any question, Kevin.
Hi, Samir. A few points that I would like to make. We would like to welcome Professor Yuha also to this presentation. You know, you were talking about many points towards the future direction. One is the lumbar puncture. And, you know, this is something that people have already tried. It is not that they haven't tried. There are many papers that has talked about not immediate benefit, but later benefits of lumbar puncture in trauma. In literature, there are many. To corticectomy, this is again something which has been done before. You know, in 50 years back, there are many papers which talk about going for the temporal lobectomy. And once you do the temporal lobectomy, you cut the tent and then you reach the cistern. Actually, what you are reaching is the suprasellar cistern. Anteriorly, you will be reaching when you take off the uncus, then you will be reaching the suprasellar cistern actually. And well, so these things are not new. People have been doing this for in many schools, many people have been doing many things. And we just put it all together. And then we went ahead and tried to explain why this works by talking about the CSF shift edema. The CSF shift edema is the basis of this cystonostomy. And another thing we understood was that if you do a good skull-based work, like in a Dawlings approach or a modified Dawlings, which we do for cystonostomy, there is no necessity to retract any brain. You directly into the cisterns. So if you can do all this, say for example, the brain, you get underneath and you then extend, you extradurally lateralize the temporal lobe. That was one of my talks before. And you do all this, you are into the cisterns. Actually, to the young neurosurgeons, if I were in your place about 10 years back, I can imagine myself that I was trying, this thing happened in an accidental way, that I tried to open cisterns and things started going north. And then from there, it has been a learning process for me, because initially I was not probably good enough technically to open the membrane of Liliequist, and later on we went to Japan and I learned it. But I always wanted to do it and improve it. And that is why it is there this time. So again, this WFNS neurotrauma meeting will have an entire session on cystonostomy. So this is in Naples. If you guys would be, John should be relaying it on TV, but we have an entire session with a cadaver session. Hopefully cadaver session, Corrado is organizing it, and we will have an entire cadaver session on cystonostomy alone. And we will have all the surgeons coming, doing cystonostomy from all over the world, from Switzerland, from rest of Europe, from Latin America, from Africa, from India, all of them coming together and then sharing their experiences. And some of these surgeons like Chinese surgeons have more than 300 cystonostomies. So these guys are very good, probably better than me. So, so they will be coming and sharing their experiences. So things are slowly moving forward. And now I have seen that you have taken this up. I'm very glad and I'm honored that you guys are looking into this. You must understand that trauma is a big part of neurosurgery. We cannot ignore it as a secondary something or something which is not important. And the only way that you will go ahead by doing good trauma surgery, you will go and do good microneurosurgery also. Anybody who does cystonostomy doesn't have a problem with aneurysm. Yuha is here. He has seen me doing cystonostomy, and I'm sure he can tell you that anybody who does good cystonostomy will not have problems with aneurysm surgeries also. And they will not have problems with anything in the interpeduncula fossa, anything in the suprasellar system. So it is not a way to start off your career by cutting off temporal lobes and doing a surgery which only 100-year-old surgery. It's a primitive surgery. You're starting off your whole residency with that. You know, you are not focusing on skills. You are not looking at the microscope. You are, whenever there is a problem, you can close. This is what decompressive hemicraniectomy allows you to. This is not right. We are going to be neurosurgeons. We are not some rickshaw drivers, or we are not somebody who doesn't need skill. We need a lot of skill. So for that, you should slowly take help from your aneurysm surgeons, start opening your cisterns, and slowly there will be problems. I'm not telling there will not be problems. In my career also, I had many problems with cystonostomy. And there were many times I had to go back and take my bone flap off. Even now, there are many times I cannot control the brain swelling. When there is ischemia, I cannot control the brain swelling sometimes. But believe me, if you start doing cystonostomy, you will understand how much better that is compared to decompressive, and how much better that is for your patient. Thank you.
Very good. Thank you. Let me just comment first. I guess we're getting okay, we'll broadcast Naples, and we hope to provide a forum for discussion on matters such as what you're talking about. And hello, Yuha, how you doing? Go ahead, Samer. Could you comment on what I've said? Do you have anything to say, Samer?
Yes, that's a talk from expert. So I think I understand what Professor Aib said, and I think he understands our intention also, that they want to do something in area. I think it's for Iraq, it's a virgin area for neurosurgery. If you know that Iraq have like 200 neurosurgeons and maybe 10 or 20 practicing microscope weekly, not daily, maybe 1 or 2 practice daily. So it's always a virgin area, but I think there is a good new generation for that. And I think cystonostomy is a bidirectional, because we can do it in trauma, and we will be like get a technique for the elective also. And on the opposite side, it's not for training for sure, but we should do it to save the life. And I accept what Professor Aib said, and I think we will start to work on these directions and with his guidance for sure. And maybe I will be there in this session for cystonostomy, maybe.
Okay, it'll be broadcast here. And the other neurosurgeons, do you have any comments on what Aib and Samer said? Juma and Carlos, and I believe Albert Sufinov's here also.
No, sir, I don't have.
Okay.
I just want to present and thanks to Professor Aib for elaboration.
Okay, very good. Carlos, are you there now? Well, I guess he isn't. And that, I believe that's Albert. Is that Dr. Sufinov? Are you there? Oh my God, we got an auditorium. In Russia. Samer, Do we have any comments from the audience there in Russia? This is great. Iraq and Russia, this is great. Does anybody have any comments at all on what on the cysternostomy? Has anyone used it, etc.? I don't know how we're going to set this up here. I don't know if you guys even have a microphone. But at any rate, I guess we'll work on the tech. But I appreciate Samer really pushing the tech and using the Hangout to include an audience of people, more than one person behind the computer. That's a really good use of this technology to bring everyone in. Okay, Samer, we'll let you control the discussion. Where do you want to go now?
I think one of my colleagues have a question for Professor Ayub about cysternostomy.
Go ahead.
Good afternoon, Dr. Ayub. I am Alfa Aksem, a resident neurosurgeon from Iraq, third year. You are talking about cysternostomy, whether traumatic or for elective surgery. And when I read that you mentioned we can put a catheter for 5 days to wash out toxic free radicals. So can we consider any presentation of toxic free radicals, non-traumatic, acute presentation, as an indication for cysternostomy? Or not? Or it's just by accident?
Did you hear the question?
You're asking me about the indications of cysternostomy?
Yeah, I asking about considering any acute presentation of free radicals, non-traumatic, as indication for cysternostomy to put a catheter for wash out these toxic free radicals.
Okay, I mean, what I understood was, is there a non-traumatic indication for cysternostomy? That's what you were asking?
Any acute presentation for non-traumatic free radicals or not?
Excuse me, Samer, could you ask the questioners to step up to the microphone, please? They might understand better if the questioners came up to the microphone. That might be better.
I think it's about the idea, not the clarity of voice. But Professor, I think also asking that if it's washing the toxins like tau and the things as one of the function of cysternostomy, can we use it in a non-traumatic setting?
Yeah. Is it what you're asking? Is
Yes,
that what you're asking?
Indication for such radicals, consider it as indication or not?
Yeah, see, there's a very interesting paper by Garnet Sutherland about the lactate storm. So whatever you think about diffuse axonal injury these days, the findings that you get in a diffuse axonal injury is the axonal retraction balls. And we think that these axonal retraction balls happen because these axons got broken and they retract. And that's why this happens. But then what Garnet did is he increased the lactate level in the brain by injecting lactate into the mouse brain. And they got the same findings, the axonal retraction balls. So they didn't have to have trauma. So this diffuse axonal injury is probably not as we know it. So the diffuse axonal injury findings can be actually made by just increasing the lactate. And we all know that after trauma, there is a lactate storm. This is because the neurons, they stop taking up the lactate for metabolism. And then there is a very, very high level of lactate in the brain. And this may be the reason why this diffuse axon, so-called diffuse axonal injury findings start happening. Well, trauma, primary trauma also plays a part, but not exactly all the time. So maybe other than CSF shift edema, this diffuse axonal injury, other than severe trauma, maybe there is a role for cysternostomy in washing out all these lactate and all the other things as well.
Okay.
Yeah. 1 second, 1 second.
Any question, John or Slaven, from the panel?
Okay, any comments or questions from the panel or from the Russian audience? I don't know if you guys can step up to the mic at all. Oh, there is a mic. Okay, do you guys in Russia have any comments or questions about the procedure of cysternostomy? Okay, here we go. Great, thank you.
Hello all. Hello all.
Thank you.
So you enjoy this neurosurgical TV. This is
Great.
This is first experience. Yes. Joined this neurosurgical TV, and we could not have questions and see.
Great. Welcome. We hope you participate in all our presentations.
Yes, I would like to just commend what Russian team did, and also of Dr. Hoz, because I think it's a great way to, you know, if you're studying art from some person, then you can discuss them here with the author. So there is lots of echo. I'm sorry.
Yeah, we're getting it somewhere. I'm not sure where.
Message that we can.
John, all you guys?
Yes.
I would like to make a comment. You know,
Sure.
I've been in this place in Russia for four years consecutively for the meeting. And I know most of the guys around here. And the guy who came and talked to the phone, talked to the mic just now, you know, once I lost all my luggage and I was supposed to address the opening of this SNS conference, and I did not, I was in my military overalls and a military boot. And the guy who just came in, he gave me his coat. I don't forget that. So he gave me his coat, and I was in his coat, and I was addressing the same auditorium. I remember that, maybe 2 or 3 years back. Do you remember?
Was that during the cold weather, right?
Yeah, that was in October, man.
Oh, wow. It's cold in Russia in October.
So I'm glad to see all of them. And yeah, I mean, I'm looking forward to see Sufyanov as well. So next is my talk, I guess.
Yes, you know, Sam was showing us a good way to use the Hangout site is have it in an auditorium where you can have more than one person, you know, there. It's an excellent use of Hangouts. That Sam was the first guy that did it. And well, we'd like to meet your students, Samar. Can we meet them right now? Samar, are you still there? Hello? You're muted, Samar.
Yes, John?
Yes, could we meet your students, please? And we'd like to meet the Russians, too.
As usual, I'm asking them if there is any question for Professor Aib or
okay.
not, and any question?
Okay, could we meet them, please? Could we meet them, please, Samar? Hold on, Slaven. Can we meet them, please?
Like they introduce themselves, or?
Yes, please.
Yes.
I am Alpha Aksen, resident neurosurgeon, third year.
I'm Dr. Muthanna, fourth resident neurosurgeon from Baghdad.
Welcome.
I'm Dr. Ivan, fifth year, board of neurosurgery.
Welcome.
Thank you,
sir. Mohammed Final, resident neurosurgeon.
Hi, Dr. John. I'm Mohammed Mohan, final year West Coast.
Welcome.
Professor, fifth year, neurosurgeon.
Welcome.
Final year. Thank you.
Welcome.
Actually, I'm a medical student, fourth grade medical student, and actually me and Dr. John have met before in Slaven presentation.
Welcome.
Hey, my good friend Slaven, happy birthday, by the way. And I have a comment on this presentation. It was a great presentation, and Dr. Summer did the basic concepts of cysternostomy in a crystal clear way. And the comment of Dr. Aiken was a great honor for us as medical students to contribute a talk with such a great neurosurgeon and the pioneer of cysternostomy and the leader of the international project in the world.
Welcome.
It was a great honor, and thanks everybody.
Super, super. Okay, very good. Okay, welcome. Very good. Very
John,
good. Yes.
John, I'd like to introduce Dr. Sergi.
Oh, Sergi. Sergi came in from Russia.
Finally, I'm here.
Yeah, Sergi.
Hello.
Как вы понимаете?
Yes, I know. Tюмень Federal Center. I know many people from there.
Oh, okay, you're very good. We're connecting you back to Tayuman. Very good. Very good. Okay, very good. Now you're all welcome to wait for Ike. Ike is giving a presentation now, so you're all welcome to stay. And Samer, we really appreciate giving your presentation, and we hope to include the Iraqi neurosurgical community in all our activities. And we welcome for them also to give presentations of their own if they wish.
John,
Okay.
hello, John.
Yes, go ahead.
John, tell me when to start and I'm ready.
Okay. Okay. Any other comments before we close Samer's talk?
Hello.
Yes, go ahead, Juma.
Yeah, I just have one question. I would like to ask Samir or Professor Aip. We get a lot of trauma patients back in my country, and we just do the compressive craniectomy, actually a large flap. I have seen no one doing cysternostomy. So I would just like to ask, when it comes to the outcome, is there any study comparing the results of the compressive craniectomy without cysternostomy and the compressive craniectomy with cysternostomy? Is there significant outcome results? Did you get it?
Yeah, Juma, I got your question. So we have published this back in 2012, I believe. There is a textbook chapter and an article in the Asian Journal of Neurosciences, which talks about our experience with decompressive hemicraniectomy, then decompressive hemicraniectomy with cysternostomy, and then cysternostomy alone. But you must understand that these were not simultaneous patients. These patients were my learning curve. In fact, I started doing cysternostomies when I started doing decompressives when I was a consultant and a final year resident. And then once I figured out opening cisterns, I did not have the courage to put the bone flap back for the first 300 cases. So I continued with decompressive hemicraniectomy plus cysternostomy. And then I graduated into cysternostomy. So we compared all these patients, their outcome, and everything has been discussed in this paper. You can get it on the web.
Thank you so much.
Okay, very good. Any more comments before we close and move on to Ike's presentation? Okay, very good. Okay, everyone's welcome to hang around. Let me just formally finish this one, so we'll edit it. Thank you very much, Dr. Hose, and we look forward to more presentations from both you and the Iraqi neurosurgical community. So thank you very much. Let's end this. Okay, Ike, we'll start yours right now, okay? Let me just introduce you formally, okay? Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett from Miami, broadcasting for Neurosurgical TV. on our fifth Sunday of neurosurgery presentations. Today we have the honor of having a gentleman I had the fortune of spending 3 months with in Nepal. I'm Cherian, a big proponent of cisternostomy, and IPE has built a wing of neurosurgery in Biratnagar, Nepal, at the Nobel Medical Center, and he's going to address that issue of having a lot of tools, neurosurgical tools. So before we turn it over to IPE, I'd like to introduce the panelists. First, we'll start with Slaven. Could you please introduce yourself?
Yes, thank you very much, Dr. Bennett. I am really honored to be here on the panel for this presentation. I'm a medical student in Croatia, leading here some neurosurgical communities of students and participating in neurosurgical TV productions. So I'm really looking forward to hear this talk. Thank you.
Thank you, Slaven. And could the Iraqi neurosurgical community just wave? That's all. Just wave. Okay. I'll introduce you again. Okay, and Rakesh, could you please introduce yourself? Oh, Rakesh, we can't hear you there. That's okay. This is Rakesh. He's a neurosurgical resident from Kolkata, India. Okay, and the next person, I don't know who you are. Yes, hi. Could you please, oh, is that Hira? Hello, could you please introduce yourself? Well, okay, we'll get better with the technology here.
That is a medical student from Morocco, Omeima, who was yesterday introduced to the Hangouts. Yes.
Okay, I believe she can't hear us probably, but can you hear us? No, you can't. Okay, we'll go on to Margarita. Margarita, how you doing?
Hello, I'm very fine, Professor. How are you? Hi, Samir. How are you?
Very good. Could you please introduce yourself and what you're doing?
Excuse me, Professor?
Yeah, you're a neurosurgical resident, correct, in Portugal?
No, Professor. I already finished. I'm a young neurosurgeon. I make my formation at Unicamp in Brazil, and my family moved out to Portugal, so I came with my mom. Now I'm living here, and I'm waiting for my validation process to achieve the neurosurgeon board here.
Okay, welcome, Margarita. And Juma? Hello, Juma? Can you unmute, please, and introduce yourself?
Hello, I'm Dr. Juma from Tanzania. I'm a spine neurosurgeon fellow in India now. I would like to hear from Professor IPE, and I would like also to be a student of Professor IPE in neurovascular, together with Professor Juha.
He may want to go to Biratnagar, right? And Carlos, a representative from the Spanish part of the world. Welcome, Carlos. Bienvenido.
Good afternoon for everybody. And thank you very much for the invitation. And I am a neurosurgeon who are working in Spain and in Ecuador. Now, at this moment, I am in Ecuador because yesterday I came here to do an operation for a tumor resection in Ecuador.
Very good. Welcome. And the Russian contingent, I guess you just can wave. Hello. Okay. Okay. Welcome to all the Russian contingent. Okay, IPE, it's all yours. Okay, you're muted. IPE, you're muted. You're muted. You unmute, IPE. Yeah. There you go.
All of you, the Russians. Hey, you guys, how are you doing? Oh.
There we go.
Right. So, I'm going to talk to you about, in brief, about the NeuroSuit. You know, what inspired me to make this NeuroSuit was, in fact, Albert Sufyanov Center. In fact, when I visited there for the first time, I had visited many other places, but I had never seen anything like that before, because it was so well equipped, and it was in the middle of nowhere. And Tumen is not a name which you have heard so many times. You have heard about Burdengo, you have heard about St. Petersburg and Tyumen. We thought it was in the wilderness. But when we went to Tyumen and we saw the kind of facilities that they had, and I thought for myself that someday I should have it. And in 3 years, we now have it. So again, after having it, I was thinking whether is it really necessary for all these fancy equipments for neurosurgery, or is it something which is an adjunct to your other skills? So this is what I'm going to be talking about. So I'm going to screen share right now. Okay, that is, can you hear me?
Yes,
can you
we
see?
can.
And
Yes,
can
we
you see?
can. Yes, we can. The NeuroSuite.
Okay, so this is our theater, not fully equipped right now, but this is how it looks. You have the MRI there, you have a Trumpf table, you have the Karl Stoss OR1 Neoprime here, you will have the O-arm on this side, you have a roof-mounted navigation here, that's a navigation camera, and you have the roof-mounted navigation panes and everything. So now let's start from the beginning. When I came to Nepal 10 years back, after finishing my residency from Vellore and doing my vascular fellowship with Sano, you know, the only thing I had was a suction and a bipolar and some you know, crude craniotomy instruments. So whether can one do neurosurgery with that? Yes, it's possible, and good neurosurgery too, although not very sophisticated. So what you need is a suction bipolar, craniotomy instruments. Of course, you need a bioneted forceps. Preferably, you should have a microscope. At that time, I had a OPMI Pico microscope. I had 4 aneurysm clips and an applicator. And well, this is all we had. And then, of course, what you need is you need common sense, you need skills, and you need the right frame of mind, which I call the right frame of mind, which I call is fearless focus. You should be focused and you should be fearless. And you know, one of the things about neurosurgery I always share with my residents, as experience comes, fear also creeps in. So what happens is 10 years back, I could take on any tumor without any fear because I did not know. But today, when I take on this kind of tumors, I think about all the complications that I had in the past. But this is not good. This makes you conservative. And this is not what you should do. Your technical skills should improve, but you should have fearless focus. So the last 3 things, common sense, skills, and fearless focus is what you really need as a surgeon, other than all your basic instruments. So why the NeuroSuite? Well, we are not getting any younger. You know, life ought to be easier. Flaps ought to be smaller. Tumor resections, clipping, and other procedures could be done in one sitting instead of figuring out on a CT that, oh, half the tumor was left, and then you go back and open it again. And when you become older, maybe this is not a very comfortable thing to do. And then decreased risk of missing levels, and in spine, wrong craniotomies, ergonomics, better performance. Then, of course, there is a feel-good factor that I have all the things. I have all these things. So it feels like a cockpit inside your theater, and you have the feel-good factor. And then, of course, marketing. You can always tell your friends that, yeah, you could send this patient to me. We have literally everything. So this is what the NeuroSuite is for, to be very, very frank. So you can see a few of the things. That is a Pentero microscope in the NeuroSuite. That is a robotic arm. That's a Mitaka poinsettia arm. where I can mount my endoscope. I can simultaneously operate with my microscope and my endoscope to give me different perspectives, and both are navigated. Each of my instrument through Medtronic SureTrack, we can navigate each of my instruments. That is our ICU, one of the ICU. This is a conference room where all the 3 OT feeds can be taken, just like in Tumen. We can take all the 3 OT feeds and project it here, or send directly to neurosurgical TV. Well, the heart of this NeuroSuite, you must understand, is communication. So just like in Albert's room, we have a large PACS monitor, 6K PACS monitor. So this is the picture of an epidermoid, which we just did. We just finished it without any problems. So that is a PACS monitor's accessory. That is my desktop, which along with my OT feeds can be projected to a large TV monitor there. So this is communication. So from my room, I can appear in all 3 OTs. I can know what their planning is. I can know what they are doing. I would be able to understand what is the navigation procedures going on and the planning in each OT. Literally, I can send these pictures like this into my OT. This same screen can be seen in my OT. Well, this is the next room. Just next to my office is my restroom, and this is the stealth station, including the bottle of wine, which is not actually wine, it's fermented tea. So that is the stealth station. That's my private stealth station. So you can actually plan every single procedure, fuse MRI, CT, everything, do a planning and send it to the theater. Or the theater guys can send a plan. Say, for example, they've done an O-arm picture and they can send this O-arm picture to me, and I can fuse it with the tumor, and then I can send it back to them. So from my room, from my resting room, I can literally tell them, boys, this is what I want to do. So I'm going to show you a small video. So that is the Medtronic roof-mounted i7. So the beauty of it, it has automatic registration with the MRI. The moment the MRI is done on this screen, it's registered, and the registered image can be injected. Registered image can come onto my microscope, and there can be image overlay, and the microscope itself is navigated. So you can see that. I will show you the microscope. The microscope itself is navigated. So when the patient lies down, before even opening the craniotomy, I can put the microscope on top of the head, and I will be able to know where the tumor is, and which angle am I looking at, and where is the tumor bulk maximally, or where is the aneurysm, which angle is the aneurysm going to be. Everything I can figure out. So that is now that is the navigating part of the microscope. So that is what I was telling you, that this microscope is navigable, and you can see the mouth switch there. Juha uses that a lot. So you can see the 3D monitor Trinion, 3D Trinion monitor, and that is behind you is the endoscope, the SPICE cameras, and the 3D monitor for the endoscope, and behind that door is the MRI door behind me. So this is the complete NeuroSuite. I'm telling some nonsense to the journalists. I mean, this is another thing. Yeah, so that is a TRUMPF table. This works with the Siemens intraop MRI. This is this table can load on to the next trolley and go directly to the MRI. And this is a Karl Stoll's OR1 Neo Prime. So this is multiple inputs, multiple outputs. That is the IDA system, and that can come and that can be navigated. Well, this is my stealth station, as I was telling you. This is a fusion. I'm fusing it, and that can come onto my screen here. That was the one which you saw was my restroom, and that can come into my navigation screen here. I can navigate both my endoscope and my microscope together even though I have two perspectives, and I can inject those images into my microscope eyepiece. So with the image injection. So that is the endoscope. This is dual view, and it has a 3D monitor as well but we generally use SPICE cameras, and we also have the Mitaka arm, which is the Mitaka, the robotic Mitaka arm. I mean the pneumatic Mitaka arm, which will help you to keep the endoscope. I mean, act like an endoscope holder, but I think I like it more as a handrest than an endoscope holder. I like it, and of course we are talking about the various things that we can do with this microscope. Of course, that is the O-arm. Now the O-arm, this is the O-arm 2, which has a skull-based module also. Literally, it can be used like a CT in the skull-based cases, like for example in pituitaries or extended skull-base, or when you're doing endoscope. And the O-arm has automatic registration, so the navigation is ready as soon as the image is done. It's ready. And plus, of course, you can do all the spine cases. That is what it was meant for. But for a skull-based surgeon like me, it is very useful because you can know where your anterior petrosectomy has to end, or where what is when you're doing well, that is your intraop MRI. So this is a 2-room solution, as you can see. This is a 3 Tesla MRI with functional and every single neuro protocols on. So from my theater, I can get into this the patient can get into this MRI with just a single transfer. So we have the transfer trolley and everything, and this MRI has an automatic registration. So the moment the MRI is done, it will come onto my navigation. There is no need to be transferred through PACS or anything. It will come directly into my navigation because it is equipped with the auto registration. Well, that is my team, and that is the most important thing, of course. Well, that is it. I must say that this was inspired by Albert, and there are many other things like, see that is a robotic arm. You can see the robotic arm there. That is the Mitaka arm. So there are many more things, but more importantly, I was just telling you, although you have a suction bipolar and common sense and skill, you can do most of your cases. But this I find is a luxury, and it is not bad. Thank you very much.
Very good. Could you just go through when you first got the idea to do this, and just the big moves to get it going? Could you just basically go over that when you had the idea to do this?
Yeah, see, we've been doing lectures for over 8-9 years now, and whenever you go to a place, one of the most condescending and sad comments that you hear is, yeah, I mean, even though you don't have anything in Nepal, I'm glad that you can do all this. So this is something which, you know, neurosurgeons are arrogant people. We are all arrogant people. And although we don't show it completely, but it is, we are proud people, of course. And when somebody tells you that even though you don't have anything, you can manage to do all this, and that is second hand. I don't like second hand. So that was the reason I decided, okay, enough with all this. Wherever I am in Nepal or wherever, I'll do this. I mean, that is the truth. I can say, I can sugarcoat it or do whatever, but this is the truth. I did not want to hear this anymore. So if anybody told me, I would tell him that I'm more equipped than you are. So sorry, I can do this better. So that is the reason, number one. Number two, of course, when I went to Tumen and I saw all these things, how Albert has done it, it gave me a lot of ideas. It gave me how to integrate many things and get it all together. And then when I have done this, now I realize that most of these cases actually don't need this. For example, a person like Juha, he will not really need navigation because for 30 years he has done cases without anything. So it is in his head. So he doesn't need any of these fancy tools to do an excellent aneurysm surgery. By the time you start registering and everything, he'll finish his clipping and get out. So, well, but this is progress. This is how things are moving forward. And I like it. After I have established it, I really like it. So if this is the the real thing behind it, if you ask me. But of course, you don't tell all that to everybody. You say that, yeah, I mean, I want to do it and I managed to do it and I'm thankful that I did it and all that. But this is the real reason.
Well, you know, we hope we use this technology to bring to the world what both you and you are doing in Toronto, and we hope to have time. We'll hope to be able to show the world what they're doing there too. So, any other questions and comments from the panel on what I'm doing in Biratnagar?
Hello, I am Carlos from.
Seems like Carlos is right. Dr. Carlos.
Hello. Hello.
Carlos, are you trying to talk? Let me see if I can get you. No.
Hello. Do you listen me?
Yeah, you're muted.
I can't hear you, Carlos. You're muted.
Hello.
No. Still can't hear you, Carlos.
Hello.
Well, I'm getting a lot of feedback on my mic. I don't know what's going on.
The first time is, I think, is
okay.
Congratulations.
Yes.
Also, like,
well, I would just like to say, although I'm not experienced in this, I think that, you know, what I see here is really incredible. I mean, based on the equipment we have in the best center here in Zagreb, in Croatia, this is like 31st century. So, I mean, we have what is the name of the microscope? The version which was hot prior to Pentero, before it went out. I cannot remember the name now, but in navigation and other things. But I mean, it's really remarkable to see what Dr. Cherian has made there. And I mean, I like very much how he remarked on Professor Hernesniemi's surgeries, because I was privileged to download an application of Helsinki neurosurgical videos, which was the only way to see Dr. Juha operate before. It was on App Store. I don't know how, but there were some videos of his openings and how he does some procedures, and you can really tell. I mean, what is the mind of the professor, how he thinks, and I'm constantly amazed by this. So I think that this top level presentation is really bringing us all to another level of thinking. And I'm really happy that I had the chance to attend this again, to you know, because if you start thinking in as Professor Cherian said, you need to blow out the box. And if you start thinking this level, it really enables you to do more things than just one process of thinking. I would just also like to mention a person while I'm speaking. Let me just check. There is a neurosurgeon who is a functional neurosurgeon who does not use anything except neuronavigation, I think. And he's able to do everything. I just, Hugh Dufault. I think that is his name. And what is interesting, he doesn't even use an operating microscope. So can I just ask for a comment on this, for example, because when Professor Type touched this subject of, how can I say, all the equipment full with a tool, and how people have it in their heads, and what is the difference here? He has excellent results, and at the same time, he really kind of neglects all the equipment. He said, you cannot change yourself, find yourself. But I think is this risky for the patient? Can you please comment maybe on this?
Microscope? He doesn't use a microscope?
Doesn't use the microscope. He doesn't use anything. He just uses neural navigation, I think.
Yeah, that is all. A functional guy just needs to do a navigation. He doesn't need to, because the only thing a functional guy would put in is a burr hole, and then he puts in a needle. So you don't need to. You put in a needle through completely based on navigation. You really don't need the microscope there.
Yeah, but he wasn't using stereotaxy. He was using basically a resection of the temporal lobe and so on. So he was doing basically resective procedures, and without using microscope. For example, operating in the eloquent areas of the brain and so on. So this was pretty strange when I read this.
He must be very good.
But it is possible.
Okay. May I comment about the non-using of microscope? So
please, Professor,
like the Beatles have a song "Back to '60s." So it is not acceptable to operate on the brain without microscope. So if you do that, then you lose so much. So you cannot do well. When the microsurgery came, so there was big resistance, and those who were resisting microscope, they were saying that really good neurosurgeons don't need microscope. But this is nonsense. This is nonsense, because the microscope is the thing. Maybe in the future we don't need the microscope, but until now, so we have to use the microscope because you see better. It is giving beautiful magnification, and then you see three-dimensionally. This is completely different than from the loops. With the loops, you can have magnification and maybe also light, but you don't have the 3D visualization inside the cranium. So I think it is extremely important. So your attitude should be that you even eat with the microscope. Always use microscope.
Thank you.
Dr. Hiersnemi, in what particular types of cases would you definitely need a microscope? Would you say?
Yeah.
In what particular type of brain problems would you definitely need a microscope?
You ask me? Or
yeah, I'm asking you.
I'm using in every case. So since 1980 in spinal cases, and I do also trauma cases. Of course, now I don't have access to trauma cases, but in Helsinki I used to do also trauma cases under the microscope and closing under the microscope, because this gives extremely good training in using microscope. So to get familiar with the microscope, you have to use it everywhere. So it is. I think if you take the microscope only for a short moment to, for example, clip the aneurysm or take the tumor out, so then you lose many of the things. So I think extremely important to use all the time, and to use the mouthpiece with the microscope makes the operations 40% faster. So you are doing fast surgery, and you can do many cases. So I have done 6 aneurysm cases in one room in one day. So this shows that how effective you can be.
So you would encourage your neurosurgical resident to use a microscope as much as possible?
Even more.
Okay. Okay, very good. Any other questions or comments for Hype and Juha on this topic of tools in neurosurgery?
Dr. Slavin, since you mentioned it's Dr. Hugh Defoe.
Yeah, the Hugh Defoe. Yeah.
There is a study of him where he proves that the language area, that speech area of Broca, doesn't exist
Doesn't
in
exist,
every
I know.
book-
Yes.
Yeah, and he said he has a book which called the mistake of Broca, and where he tried to say that there is not a specific area in the brain that is specific for speech. I recommend to read it and to discover it.
Yes, well, you know, he has huge followers here in Zagreb at our clinic of neurosurgery at the University Hospital Center. They say that, you know, on the lecture which I heard recently, they said that there is no such thing as Broca area, and it was quite, how can I say, this is, I think, functional way of thinking, you know, because there is, it is much different, you know, the correlation between anatomy, and because the first way that Broca's area was identified was with histology of the brain. And when you see different layers of the cortex, how they look, that was the way they interpreted this as the region, and they just added function. But if you look functionally, more areas exist, and I think that we can agree that if part of the Broca's area is resected on a man's hemisphere dominant, a man cannot talk again. I mean, for women it is different, but it is. So I must say that this is a very interesting subject that they put in, and this same surgeon does not, as I said, use microscope, and he had this maxim. He said, "You cannot change yourself, find yourself." But I really agree with Professor Hernesniemi, and I wrote down, "You should eat with the microscope." So really, thank you.
Okay, very good. Okay. Any other comments or questions before we move on to Juha's presentation?
Hello. Do you listen me?
Mr. Professor,
Okay, go ahead.
how many beds have in the center?
This question is for Ipe, I think. Ipe? He asked Ipe, is a neurosurgeon, as a resident from Russia, how many beds in the center?
How many?
How many beds are in your wing of neurosurgery?
Yeah, we have 43 ICU beds and about 115 beds for neurosurgery.
Hello.
Professor, tell us please, how many operations do you have per day?
No, we have just started. We have just started the center. We have just started. It is less than. Maybe right now the neuro center. Only the old setup has been started. The new center has actually not yet been operational. So I cannot really comment on. Right now we have about maybe 1 or 2 operations per day, but I'm sure we are serving a population of 40 million. Maybe 40 million people are going to be draining to this area, adjoining to the adjoining India and Nepal. And no place in that area has any center which is equipped like this. So we probably must be doing much more than that. Right now, it has just started, so we are only doing 1 or 2 cases per day.
Okay, very good. Another question from Russia.
Kind of operation do you do in your center?
What kind?
Operation,
Are you-
functional epilepsy, and aneurysm surgery, and other, for example.
Yeah, man, you should probably ask Albert what I do.
I don't know, is Albert in the auditorium now? I saw him stop by briefly.
Yeah, we do everything literally. We do aneurysms, AVMs, tumors, anything except functional neurosurgery, which has not been started now. We do literally everything. All skull base, I do primarily skull base and vascular. Juha does vascular tumors. We have our spine group, so we do everything. It's and Albert knows.
Okay, very good.
I have one more question.
Yes.
Go ahead.
Use your intraoperative MRI and for epilepsy surgery.
I see. The point is we really haven't started using everything. So we are just in the phase of establishing it. So yes, of course, I am not an expert on epilepsy surgery, but in your center, the epilepsy surgery started after Roy came there. Roy is my very good friend. I brought him there. So you started your epilepsy surgery with Roy. So maybe you should ask Albert about the history of starting epilepsy in Tumen. So I brought Roy down there and Roy was staying there, I remember. But I worked with Roy for 6 years in Vellore, and we do amygdala hypocapectomies and all the suprainsular, infrainsular window. But this is not my interest. But of course, yes, when I have my MRI, I could probably invite one of you guys who are good with epilepsy surgery. I could invite you guys so that I can learn from you guys.
Okay, very good. Very good. Okay. Okay, I guess we'll close this talk, Ike. I really appreciate you coming and talking about your center. We'll continue to follow what's going on in Biratnagar. It's going to be hopefully a center of neurosurgical education with the aid of Neurosurgical TV. Okay, so we'll end this talk. And thanks to everyone for coming. And just sit tight. Juha is going to give a presentation now, which will be especially valuable to the residents. So thank you very much. We'll end this formally, and we'll see you in the next talk. Thank you. Okay, we'll edit that, and then we'll start Juha's talk. Juha's going to talk about random cases from a master. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami. This is Dr. John Bennett broadcasting for Neurosurgical TV. We have another in the episode of Super Sunday, the 5th Sunday we've had presentations from a core of Dr. Cherian, Juha Hernes-Niemi, and Victor Hugo Perez, as well as other neurosurgeons such as Albert Sufianov later on today. And today we have the honor of having Juha Hernes-Niemi from Finland, a noted neurosurgeon that's done a lot of videos, who's going to be an excellent teacher for the neurosurgical residents of the world. And we hope to use this technology to use it to bring Juha's experience. Before we go on to that, let's introduce the panel, and we'll start on the right with Carlos. Carlos, can you please introduce yourself?
Yeah, good morning.
Well,
I'm
okay.
Carlos.
We're not hearing you, Carlos. Carlos Yumaguano from Ecuador and Spain. He's in Ecuador right now, and we'll get his audio fixed. Juma, could you please introduce yourself, please? Hello, Juma. Are you there? Could you please unmute your microphone?
Okay.
Juma. There you go.
I'm Dr. Juma, a neurosurgery fellow from Tanzania. I have a honor to listen to a lecture of Professor Juha.
Welcome, Juma. And Margarita, could you please introduce yourself? Oh, you're muted, Margarita. Unmute yourself.
Okay. Hi, everybody. It's a pleasure to be here. Thanks for the opportunity. I'm Margarida, young neurosurgeon, born in Brazil, now living in Portugal.
You're welcome, Margarita. And Umaima from Morocco. Can you unmute, please, and introduce yourself?
Hello, I'm Umaima, medical student, a third year in Morocco. I'm really glad to be here and to share knowledge with you. Thank you.
But you're from Morocco, correct? We didn't get that in the audio. Okay, Rakesh, can you please introduce yourself? Go ahead, Rakesh. Oh, I guess we're having audio with him. Slaven, Rakesh is a medical resident from Kolkata, India. And Slaven, could you please introduce?
Yes, hello everyone. I'll just go briefly. I'm Slaven from Croatia. I'm currently in Zagreb, and I'm here participating in many events in neurosurgery. Apart from the OR work, also I'm leading the Walter Reed Andy Neurosurgical Society here, and I'm also doing a Roton course, which is an international course in neuroanatomy, which I started with Professor Roton 2 months before he died 3 years ago. So thank you very much for being able to hear another perfect presentation from great, how can I say, I'm a great believer in Professor Ernest Niemi, and I'm really privileged to be here to hear his talk.
Okay, thank you, Slaven. Could you please mute yourself? And Dr. Sufianov, welcome. Welcome, Dr. Sufianov.
Hi, everybody. Siberia, from Federal Center of Neurosurgery, and good day to Professor Ernest Niemi and to I. And we listen very.
Albert,
how are you?
Hey, brother.
There we go. The personal connection. Welcome, Dr. Sufianov. We're glad to have you and your Russian community participate, and welcome.
Hey, Albert, Yuha.
Thank you very much. Thank you.
Yuha.
Good wishes. Good wishes. We wait, Professor Ernest Niemi, here in Siberia.
Very good. Okay, it's all yours.
Okay.
Albert was the reason why, John and all you guys should know that Albert Center was the reason why we started this center like this. And I called him for the inauguration, but this guy is a member of the Russian Duma, so he's a very busy and very political and powerful guy, so he could not come this time. But he has come to Nepal, he has been in my farm, and we are brothers.
Of course. Thank you very much for introduction me. Thank you very much. Thank you.
Okay.
Amen.
Okay, Yuha, it's all yours. You can begin your presentation, Yuha.
Okay.
Yes.
Yeah, Yuha is going to share the screen, guys. So
okay.
Okay. Hello, everybody. So I will show 3 or 4 unedited aneurysm surgery videos. I think it is very important to show unedited videos because we are seeing extremely many times edited videos. Operation might be 10 hours, 5 hours, and you see only few minutes. So this is intradural part unedited in carotid posterior communicating aneurysm, ruptured one. You see here the preoperative CT angio, and it is small aneurysm, but small aneurysms also rupture. So this is the lateral supraorbital approach, just showing the beginning here, but the intradural part is totally unedited, and I think it is important to show that also. So here you see that the dura is now open, and you see the brain is red, angry, swollen, even black because of the heavy suprarachnoid bleeding, but there is also subdural hematoma here. So it was not the brain, it was the subdural hematoma. Posterior communicating aneurysm produce sometimes acute subdural hematoma, which you see here sectioned out, and now actually the brain surface looks rather good. Good anesthesia, slack brain, this is the condition. Extremely important. And you see all the time the movements, they are not taken away here. The movements are coming from the mouthpiece, because I'm biting the mouthpiece all the time and moving the microscope, so I can operate all the time with two hands and not adjust the microscope, except in some moments when changing the angle of the microscope. So I take the other hand to help. And here we go, left side, and then I take the highest magnification of this microscope. This is Pentra microscope here, like here, also in Nobel Institute, very good ventral microscopes with the switch, and then I go to the optic nerve, and my regular pipolar, the length of the pipolar is the length from the surface to the optic nerve. So you know where you should find the optic nerve. And then again, changes, don't get dizzy when you see that, but I look for the good angle, and you see that I'm retracting with my sucker here. Retracting, this is the arachnoid, and I'm dissecting here. I should take now microschizo to cut the arachnoid, but what I want to do here is I want to find lamina terminalis and changing the angle again and dissect posterior and medially. And why the guy is not taking microschizo? Should take microschizo here. You see that the arachnoid is distended here. So I usually, many times I use microschizos and then do the opening of lamina terminalis. I do with microschizos. And here, of course, here between optic and carotid, you will come to the Lillekist membrane, depending on the aneurysm site. So it is sometimes helpful to go to the Lillekist membrane, do the cisternostomy there, so you get a lot of space when the CSF is coming to the Lillekist membrane. And again, changing the angle, and I'm retracting all the time with the pipolar. Now we have operated from dura open 4 minutes, opening with the Yasakil microschizos. Here you see that the old micro instruments look extremely big, like crocodile or dododile, like Yipes' daughter is calling them. It looks very big under high magnification. And now I was looking where is the aneurysm. And when you go for posterior communicating artery aneurysms, so you should go first medially, not to come directly to the aneurysm. And here I dissect proximally carotid artery, take a look how the carotid artery is, where is the posterior communicating, and then I should also know where is the anterior carotid artery, the most important branch of the carotid artery, at least for the patient, because if you occlude carotid artery, so it is very non-forgiving artery, seldom you can occlude carotid artery so that the patient has not huge deficits. So this is sure. And you see that there's a lot of blood. It is severe subarachnoid hemorrhage. I use water dissection here, inject water all the time to clean the area, to have blood away. And now you see that I put a retractor there. Why I put a retractor? It is not to compress the prey, but just to support the prey. It is like a third hand here. I'm not using the retractor to get space. Space was cut here by opening the Lillekist membrane. I didn't open in this case the lamina terminalis. Like as you saw, my intention was to do it. And now I dissect proximally on the carotid artery, sharp arachnoid fibers, and you saw what happened. Very small branch of the carotid artery was torn. What to do in this situation? Don't panic. We have pipolar coagulation. It is not aneurysm that is ruptured. I hope so. I think so. I would put here a temporary clip. Yeah, temporary clip. So the surgeon is doing well. I put a temporary clip and then think about the situation. And now, oh my goodness, it's bleeding a lot. I didn't see this video, so it is an interesting situation here. It's bleeding, and bleeding from where? Usually it is the aneurysm that is ruptured, and because it is increasing the aneurysm, the bleeding is increasing, so it should come from the aneurysm, but maybe not. It doesn't look typical. Aneurysm would bleed from the base. But the bleeding can be so that it is changing the direction, so you don't always know. So cleaning the situation, I have temporary clip here. And study carefully. And put another temporary clip distally, so we have isolated except posterior communicating artery, the area here, and now changing again the angle and searching for the bleeding. Where is the bleeding coming? Where is the bleeding coming? I don't know yet. I don't know yet. But it might be that sometimes the rupture is at the base of the aneurysm, but this is extremely seldom. What I'm doing now, I take a curved clip and check where is the posterior communicating artery. I think the clip was too large, so I have to take a smaller curved clip here to adapt to the aneurysm. Aneurysm was, well, now I take a straight clip here. Straight clip. Straight clip is more easy to push on the base. This aneurysm is ruptured. Aneurysm is ruptured because it is getting slack and bleeding. So I collect the aneurysm inside the clip. And this looks rather large here. So let's see how we solve the situation here. Bleeding stops. Okay. So the aneurysm ruptured. I think it is in the inferior surface, and then the blood is coming through the returned by dura, and it's proximally close to the carotid artery. So I'm checking the situation once more. Clip is not good. The clip is not good. This is oblique on the aneurysm. I open the clip. And with the clip, you should work as long as this ideally. And you see that I didn't finish all the arachnoid dissection here. Bleeding, bleeding. Don't get desperate here. Don't get desperate here. Because if you panic and get desperate, so you are not doing well. So calm down, and the small aneurysms are dangerous because they have extremely little substance there. Okay. So we should clean the area now. We should clean the area now. And now this is what we call pilot clip. It is stopping the bleeding, but it's not exactly taking the aneurysm base. So still the temporary clips are there. I can see that they are less than 5 minutes. And now I come with a curved clip to take all the base of the aneurysm, but also saving the posterior communicating artery and carotid artery. And now it looks good. So the clip is taking all the base. And now I begin to remove the temporary clips. Don't take temporary clip immediately out. Here I took, but if You should open the temporary clip first, and then after waiting, if there's any bleeding, then you take it out. And now I open the proximal clip, and no bleeding. And are we happy now? Of course we are happy because we stopped the bleeding, but maybe the aneurysm is not optimally like 80. So we take this pilot clip, first clip out, and then I think now we should clean. Here you see that the aneurysm is ruptured and completely collapsed, and you see the extremely thin wall of the aneurysm, and the clip is there, but some base of the aneurysm remains. So we use here the double clip technique. So there's one clip on the aneurysm, and then we put the same clip, identical clip, proximally, because the first clip is pressing the second one close to the carotid or the vessel. It is pressing it down, and the first clip is holding the second clip, the proximal clip, in the place. So I think I'm planning here that now we check PCAM from medial side. And this is an ICG angiography. We check that the PCAM is open and the carotid artery is open. As mentioned, the anterior carotid artery is extremely important. So if you have the anterior carotid artery inside the clip, then the patient has usually severe deficit. And you see that the PCAM can be seen here medially, very strong PCAM. It should be preserved, and then the aneurysm is of course not visualized because this collapsed. And but you see also the few substance of the aneurysm. And as I mentioned, so the small aneurysms are extremely dangerous because they have very little substance. And I think I would put one more clip here, and it's coming here. So the similar clip is coming here and taking all the remnant of the base. And now we know that the posterior communicating is open. Of course, it needs some tricks to put the clip here. One of the important tricks is that the clip should be the same curve or straight, similar or exactly the same clips. Otherwise, it is extremely difficult to put them. And now cleaning, and now I see that the time here is 16 minutes from going from the basally. So this is without any editing here. And here is once more checking with the Doppler flow. I check the posterior communicating artery flow with Doppler probe. And then we begin the close. Take a little bit smaller magnification and Dura, and every layer is closed under microscope. And you see that for a while there was a retractor, but usually I have two retractors. This is the Saxon and the bipolar. And you see here the situation, and some hemostat is put here, and you see that now the brain is slack and it looks good. And this is papaverine in the cotton to reduce the vasospasm caused by the manipulation. So, and this is postoperative CT angio, and looks perfect. Vessels are open and aneurysm is gone. So, where to take it? Then I take the next case. I show now here unruptured. Oh, sorry. Unruptured. What's this? This one? Yes. Okay. This is unedited video of proximal middle cerebral artery aneurysm, unruptured aneurysm. It shows better the techniques of the aneurysm surgery if the aneurysm is unruptured. Of course, if it is ruptured, it's more challenging, but principally the same. So this is M1, proximal middle cerebral artery aneurysm, and important in this M1 aneurysm is that there is always a branch coming from the base of the aneurysm. And in this way, it is not good for endovascular surgery. You can push stents and clips, and but the simple clip on the base of these aneurysms is the best solution, because the simple clip is pushing the intima together, and it gives the permanent good solution. Here, under high magnification, I'm opening now cisterns, and all the time shaking of the microscope. With the stable microscope, you got, of course, more beautiful videos, but it takes time. And now this is water dissection. I expand the arachnoid system here. Subarachnoid system here. I push water. I inject with my hand, delicate pushing, and then subarachnoid space is expanded, and it's more easy to cut sharply. So I open here with microschizos. Cause the bleeding here, small venous bleeding. Principally, you should not take any veins. I try always to save all the veins. Of course, you can sacrifice some veins, but if you try to save all the structures, then you are doing better surgery and the patient is doing better. So we check here. We check in this proximal middle cerebral artery aneurysm. We check the carotid artery here, and then go to the carotid bifurcation. And then here we saw that the distance from carotid bifurcation is rather short. So here we go proximally to the middle cerebral artery aneurysms. Otherwise, I usually go from distally. In regular middle cerebral artery aneurysms, I open distally the Sylvian fissure and go that way to the middle cerebral artery aneurysm, not going first down to approach the middle cerebral artery aneurysm, and then dissecting retrogradely. This is not the way I'm doing. So even as a very young neurosurgeon, I was wondering if we could go distally, and I have done this. So like the many videos. So, and now we come to this unruptured aneurysm, and even it looks small. So during the operation, we see how is the wall of the aneurysm. And here we see that the aneurysm wall is very thin, and even it is small, less than 7 millimeter aneurysm. it is justified to operate on this aneurysm in good hands because this gives better result than just conservative treatment. Whatever ISUA study is saying. I think the 7 mm came from Dr. Drake. He said that with that time technique, so it was not so easy to clip small aneurysms, so he decided many times just to wrap them in cotton and was concentrating on bigger aneurysm or ruptured aneurysm. Here I caused some bleeding. What is making the surgery long? It is the bleedings which you are causing during the operation. I think here also the high magnification shows every small bleeding. So bleeding is minimal here. I'm dissecting around the aneurysm, small venous bleeding here. And as mentioned, this is unedited video. So now we have spent 5.5 minutes from intradural approach to the aneurysm. I should put some cotton there to compress the bleeding. I use cottons without strings here because my experience, we are always doing our experience because of complications I have. I don't use the strings because the strings may be attached to the small vessels or even cranial nerves, and so in this way I decided not to use the strings in the cottons. And here the aneurysm is we have dissected the aneurysm space here. Well, now I put cottons to cover the area and to have a clean field. And as mentioned, we should think that in M1 aneurysms, always one vessel is coming from the base. So these aneurysms are extremely prone to complications if you just put the clip and don't check where the vessel is coming from the base, close to the base of the aneurysm. So other aneurysms like that are vertebral pica aneurysm, basilar superior cerebellar artery aneurysm, and pericallosal artery aneurysm. So there are 4 aneurysms where always the branch is coming from the base or close to the base of the aneurysm, and I think these aneurysms should be operated on because they need extremely complicated endovascular solutions. So checking here, position of the clip, if the clip has taken everything of the aneurysm out, and also checking if the small branch or bigger branch anterior temporal is open. Here I manipulate the aneurysm, check, and coagulate it a little bit. Here I'm waiting for the ICG. It was not here included, but it was unedited video, so 8 minutes intradural part. And then I saw one more video. So I saw vertebral pica aneurysm. It was here. Yeah. Oh, this one, yeah. Okay, this is unruptured vertebra pica aneurysm. In Helsinki, we had a large collection, around 200, more than 200 vertebra aneurysms, and one subgroup is the classical vertebral pica aneurysm, usually located on the left side and sometimes on the dominant vertebral artery, and more common in females. And you see here that the aneurysm is small, and you saw also that the branch is coming from the base of the aneurysm. And this is how I'm used to do this vertebral pica aneurysms. So small suboccipital craniotomy, so-called thick craniotomy, and most important thing, according to my experience, is how high this aneurysm is from the foramen magnum. If it is 10 millimeters or more above foramen magnum, then you can do these aneurysms through very simple lateral suboccipital craniotomy used in Janetta operations or acoustic neurinomas. But if it is more proximal, close to the foramen magnum, then you have to remove more laterally. And I'm not making extremely lateral approaches. I call my approach enough lateral. So you remove as much bone as is needed for safe operations. You see here the lower cranial nerves, and you see the arachnoid system dissecting sharply, and you see also the aneurysm here, unruptured aneurysm, broad base, and you saw also the pica here. And then we dissect more proximally now here, and to find a place where put the temporary clip on the vertebral artery. I never thought that when you have two vertebral arteries that you should calculate the time, but in the recent publications on vertebral aneurysm operations, Dr. Chahadi found in his PhD study that the clip on vertebral artery should not be more than 18 minutes. Otherwise, you have complications. So you should take care that you put the clip, and then within 18 minutes, clip the aneurysm or take the temporary clip out. Of course, you can apply it second time, and then you can prolong the time needed for temporary clip. I have always felt safe when I have on the ipsilateral vertebral artery the temporary clip, and I'm here dissecting a good place. You have to check a place from vertebral artery where there are no perforators, and good place dissecting here arachnoid with the microschissos, and then using a small dissector. This dissector has the same breadth than the Mitsuho clip. So if you put the so-called Tsukita clip in place, and you have placed this micro dissector on both sides of the base of the aneurysm, so you are sure that the clip is going to this small hole caused by the micro dissector. And now you see the shaking of the microscope all the time, microscope in the mouthpiece, and then not going. It's a small gap, not small gap. So I need a smaller temporary clip here. And now I push the smaller temporary clip. I have a special slim clip applicators. So they go to very small gaps. And now we have the temporary clip here on the vertebral artery proximally. And now we go back to the aneurysm. Now we go back to the aneurysm and dissect. More safe, of course, there is flow retrograde from the other side, collateral flow. But now we dissect carefully. And why the temporary clip is here important? Because there is a small branch, small perforator going around the aneurysm, and this deserves a careful dissection because it is going to the brainstem. So you should not sacrifice it, even if it is very, very small. So I'm dissecting with my sucker, and then with the here surgeon should use the sharp technique, so not with the plump techniques. But maybe I was taking the arachnoid higher. Okay, now the alligator is coming, so the dial. And so we dissect around the aneurysm and to see the whole base. And then we have to see the pica to see all the anatomy. But here the problem is that between the two bubbles of the aneurysm, there is a small perforating branch, and we dissected 3 here with this micro dissector, and then also I take the water to dissect the vessel, because water is extremely delicate in dissecting. So I have never had annulus rupture if I inject water with my hand around the annulus more directly to the annulus. So it shows how gentle the water dissection is. Now what I'm doing, I'm putting a clip here. I didn't see the water dissection. I think it's coming in different part of this video because I was looking on this video. But now I put a straight clip and advance it below the small artery here to save it. And it doesn't look good, this clipping, but it is a pilot clip. I'm not happy with the first clip. I'm happy with the last clip, and the last clip should be as good as you can put in the place. So now we check the aneurysm not taken totally, but the purpose is this first clip was to save the small branch here. And now we check again. Oh my goodness. The guy is taking the temporary clip out. Okay, then we have to check once more the situation. So temporary clip is either opened or taken away, and carefully taken away. So you see that we are working between the lower cranial nerves, so you should be extremely careful. And here I open the clip slowly, there is no bleeding, and then draw it back. Maybe no, I pushed it more deep. Maybe it was vertebral artery was not totally occluded. So no. Checking that there is no perforator inside the temporary clip. It seems that this perforator is not doing well here, so correcting the position of the temporary clip. Slow movements here, you should not hurry, because if you make something extremely fast, then you may destroy the lower cranial nerves or small perforators here. So now I got the temporary clip out, struggling by taking it out. This is sometimes very difficult. And then we go to check the situation once more. Okay, there's a clip around the base of the aneurysm. Now we should check carefully here. Now ICG is coming. We check if the aneurysm is gone and if the pica is open. This is extremely important here. So there's a lot of discussion if posterior circulation aneurysm should be at all operated on. I have experience of more than 600 posterior circulation aneurysms, and I still think that many of them are good and well treated by open microsurgery. You see here that the vertebral artery, where is the vertebral artery is there, but where is the pica? Where is the pica? I don't see the ICG. These aneurysms are situated above or post pica, so after pica. There are rare aneurysms which are not situated below pica, but these are extremely rare. So the classical vertebral pica aneurysm is located distally as counted from pica. Now we check everything. We check everything here. Small perforators if they are inside the clip. And where is the pica? Where is the pica? We are searching for it, checking carefully. And what I'm doing now, I'm coagulating the aneurysm. I'm coagulating the aneurysm. Why I coagulate the aneurysm? To have a better view and to kill the aneurysm. To kill the aneurysm. And I here plump forceps, malleus, valgus, 15, and slowly coagulating, and then changing the bipolar that it is not stuck, and then I open the aneurysm, and now you see that the aneurysm is slack, it's not bleeding, and then I can coagulate more. But as mentioned, so this coagulation needs experience, and you should know your bipolar extremely well that you can do that. So you should not make any sports here, but make proper aneurysm surgery. Here the big microschizo is coming, and then I'm checking the situation here. And once more, I should check. I didn't dare to do anything. You see that this is unedited video, so I'm hesitating, thinking what to do, and maybe I should be happy now here. Yeah, I'm happy here. I put papaverine here to reduce the operative spasm, and this video is 15 minutes. So 15 minutes, unedited video. So here is the angio coming. Okay, it is here. So this is pica here, strong. And here, the aneurysm not feeling, of course, not feeling because it's coagulated down and opened and totally taken. So I dissect here to see if there's some remaining filling of the base. And it seems to be like Dr. Drake-Campielis was saying that the perfect clip around the base of these deadly sacs is the best treatment. So thank you very much.
Okay, very good. Let me get off this. Okay, excellent. Okay, you have to stop screen sharing there. Okay, excellent presentation as usual.
Hi guys.
And okay.
Can you see us?
Yes, we can see you. And tremendous, a valuable experience, I think, for a neurosurgical resident or a student to see this.
You can hear my voice?
Can you hear me okay, Juha?
You can hear my voice?
Yes.
Are there any comments, questions?
Yes. Can we have some comments from the residents, especially, and the neurosurgeons watching, please? Okay, here we come from Russia. Here we go.
Yeah, John?
Yes.
Yeah.
I think some Russian residents want to comment here. Here you go. Okay, Russia, go ahead.
Hello, Dr. Khartsemi. I want to say
Ernest.
thank you.
Sorry.
You can share your experience with us, young neurosurgeons. And thank you to Dr. Bennett, because now in Miami 8 a.m. and he doing it for us. My question is, how long do you allow to apply temporary clip for posterior circulation aneurysms?
I have studied carefully the largest vertebral basilar artery aneurysm series, London, Ontario, of Dr. Drake and Peerless, and there were more than 800 basilar aneurysms with temporary clipping. So the conclusion was that you should apply less than 5 minutes one-time clip and less than 15 minutes when you put it repeatedly. So below about that you have complications. But of course the basilar artery and middle cerebral artery are different. In basilar artery you have many collaterals. So be calm and be large or very small. So they are different. But these rules, 5 minutes and repeated 15 minutes together, these are very good. But I think more important is that you make good surgery, not exactly those times, but one important thing to reduce the temporary clipping is to discuss everything before temporary clipping carefully, so that you have proper clips at the table, and your scrub nurse is giving them very fast, and so you are not searching for the clips somewhere on the table. So you have those clips ready, so you can do it in 5 minutes. And I think psychological is very important, so that many people can run 1 mile below 4 minutes. So a neurosurgeon can do extremely many things in 4 minutes or less than 4 minutes. So this is important. So don't hurry, just do your work carefully, and in this way you are doing very fast.
Okay, very good. Any more questions or comments from Russia? Okay, go ahead, Margarita.
Professor, in your experience, in aneurysm of PCON, do you prefer a pterygiumnal approach or a frontal orbital zygomatic approach?
I'm not using any of them. I'm using lateral supraorbital approach in nearly all aneurysms. Lateral supraorbital approach is the frontal part of the pterygiumnal approach, and is modification from the Yasaki classical pterygiumnal approach. I don't think it is necessary to do the pterygiumnal approach. I have done since 80s lateral supraorbital approach, and in experienced hands it is extremely fast. It is 10 minutes to open the dura. So it is big difference to the classical terminal approach, which I have seen take more time. Of course, I can do it also very fast, but the lateral supra-aorta approach, 10 minutes to open the dura. So I'm using the lateral supra-aorta approach. It is also public, should be also well known.
Thank you.
Well, I have a question, if I may just continue on this matter of approaches. You mentioned in your presentation that you are using enough lateral approach, which I liked really much as another maxim. And can you please give us some, can you please comment more on this? Because I'm very interested between far lateral and extreme lateral approach. Can you give us some anatomical landmarks? How do you navigate yourself in this technique? Of approach.
One of the important things here to do the posterior fossa and lateral supraorbital approach is that you are standing when you are doing the surgery. So the patient is in Parkbench position and you are standing, so you are looking downwards. But to avoid extreme skull-base resection, long skull-base resection, laterally or extremely laterally, you lift the table high, so you look like under the roof there. So you don't have to remove the bone. So this is enough lateral. So usually I stop at the foramen jugulare or to save the jugular vein. So I'm carefully there. But one of the most important tricks is to lift the table high, and then you can see below the roof. So if you just look from above, then you have to remove more of the bone. This is one of the important tricks. Extremely important. And one of the important tricks is also that you can manipulate the cerebellum. So how to manipulate the cerebellum? So you go down to the foramen Monro, the direction of the foramen Monro, and then you take the cerebellum upwards and medially, like in your hand. So this is how to retract cerebellum. And of course, taking CSF out, this gives a shift in the brain substance, posterior fossa brain substance. So I don't agree that you have to remove so much bone laterally, even this trained in all the skull-base dissection. So there are small tricks that help you.
Thank you very much for another pearl from you. Thank you so much, Professor.
Okay, any comments from the other neurosurgeons? Yuma, do you have anything to say to Dr. Hanaziemi? Well, silent. Prakash, Umama, or any of the Russian residents watching? Albert, do you have any questions, comments, or questions for?
Seems that the Russian team is.
I hope they're not watching. I hope they're not watching TV.
Yes, they are watching, but it's neurosurgical TV.
Okay, very good. We'll get better at this tech once we learn how to use it. But it's an invaluable experience to sit down with people like Ip and Juha. I mean, these are residents that are so far away that are able to interact with them. But I'm sure we'll get better with the tech.
I'm sorry to take up the space, but I will again. I can still not stop thinking about you should eat with the microscope. It's the sentence of the day for me. Perfect. It's perfect.
Okay. Yuma, do you have any comments or questions for either Juha or Ike?
No comments, sir.
Okay, very good. Very good. Carlos? Carlos, well, okay.
Maybe Rakesh has something to say.
Rakesh, do you have any comments or questions? We'll get better with this, Yuha. We're just starting.
Rakesh, I also heard from Pakistan. They are very sorry that they couldn't join, but they followed the speech on YouTube.
Yeah, let me just reiterate. I really like what Russians are doing now, getting a lot of people in one room that enable people to come up and ask questions. And I'm sure as we develop this platform, other countries will become more comfortable with having a room full of people watch someone like Yuha or I give a presentation, then coming up. We're learning this platform and we'll get better at it. But for now, I guess it's a low point. Okay, very good. I guess unless there's any other comments, I guess we can close and move on to Albert's talk. Albert, do you want to give your presentation whenever you're ready? Albert, are you ready to present? I guess you wanted to talk about Tyumen and the center there. Do you want to go to another computer, or you want to give your presentation from there? What do you want to do, Albert?
I think they're setting up.
Oh, they're setting up? Okay.
Yeah, I see that
okay.
the presenter is just setting up.
Okay, I'll just formally end this presentation. Thank you, Dr. Hernaz-Yemi and I. And I'll introduce formally Albert's talk so we can start from the beginning. Okay, thank you, panelists. Okay, we'll edit this out. We'll start it there. Let me introduce you, Albert. Okay, and we can see your face. Can we see your face and stuff to start before you go into the sharing? And this will be edited out, so don't worry about that. Can you hear me, Albert? Dr. Sufianov, can you hear me? Yeah.
Maybe they didn't understand. You should. Can you please get off the screen share for now? We would like to see the presenter before.
Hold on, Slaven. Hold on, Slaven. Only one person can run this. Okay.
I'm sorry.
It's all right. Too many commandantes. Okay. Albert, can you hear me, Albert, first of all? Okay, he'll get on the screen eventually. Okay, yeah, that's setting up. Okay, he'll get on the microphone. Okay, Albert, you ready to go? Let me introduce you. We can't hear the audio. Hold on, we can't hear you. Can't hear you. We need to fix the audio.
Okay, now it's okay?
Yeah, okay, wait, let me introduce you first, okay? Okay, hold on, Albert. Hold on.
Okay,
Can you hear me yet? Can you hear me? Can you hear me?
Okay. Yeah, okay.
Okay, let me start. Hold on. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami. This is Dr. John Bennett presenting another in a series of neurosurgical TV. We have the honor today of having Albert Sufianov, a Russian neurosurgeon, who agreed at the last minute to do a presentation on Tyumen as a neurosurgical center. He's going to talk about that. But before we turn it over to Albert, let's go through the panel and introduce the various people. We'll start with you, Slaven.
Thank you very much, Dr. Bennett. My name is Slaven Gojkovic. I'm currently in Zagreb, Croatia, where I lead the Walter Reed Andy branch here in Croatia, and also the Roton course, which I started with Professor Roton a few years ago before his death.
Okay,
and I'm really happy to be here. Thank you.
Very good. Thank you. Rakesh, could you please introduce yourself? I guess maybe Rakesh went on call. Yumala, is that the correct way to pronounce your name? Could you please introduce yourself from Morocco? Well, I guess she's, oh, there you go.
Umayma, medical student, third year.
Welcome, Yumala. Okay, Patty from Argentina. How you doing, Patty? Can you please unmute? Patty, please unmute and introduce yourself. Well, I'm not having too much luck today. Margarita, could you please introduce yourself?
Hi, everyone. Thank you very much for your experience sharing. I'm Margarida. I'm from Brazil. I'm a young neurosurgeon, now living in Portugal.
Welcome, Margarita. And Yuma, how are you? Yuma, could you please introduce yourself?
Hi, everyone. It's a pleasure to be in the panel to hear from the great neurosurgeons. I'm a young neurosurgeon from Tanzania. I'm currently doing my spine fellowship in India.
Welcome, Yuma. And Ike, could you please introduce yourself and Yuma, please?
Albert.
Okay, Albert knows you, Johan and Ike. Carlos, are you back here, back on the mic? I guess not. Oh, there you go. Okay, Carlos.
Hello, good morning for everybody. Thank you very much for this opportunity. It's a many channel where we can study a lot of.
Okay, Carlos is originally from Ecuador and Spain. So, okay, Albert, welcome and thank you for presenting, and it's all yours.
Okay. It's possible to continue, yeah?
Yes, please.
Okay.
Could you tell us a little bit about yourself, Albert, first, before you start your presentation? Well, I guess worried about the tech now.
Wait a minute.
Okay, we're busy setting up the screen share. Something that everyone has to master when they. There you go. We can see it. Very good.
Okay. Time for everybody. I'm Albert Sofianov from Tyumen, from Russia, from Federal Center of Neurosurgery. And in this presentation, at first, I want to speak, thank you very much for IPE and Professor Juha Hernisiemi for inviting us for this program. It is very important for us and very interesting to have such kind of experience. And so our presentation is about our possibility for the residency program, high residency program for young neurosurgical residents. So neurosurgery is, as we know, a very complex and high-tech branch of surgery and branch of medicine. So why of the program and for clinic residents is a key factor for the future career for neurosurgeons. So why it's very easy. Bad neurosurgeon and strong clinic, strong residency program, strong neurosurgeons. It's very important for the patients. We have also our federal center have also a residency program, and we stay in Tyumen city. Tyumen is one of the largest city and the administrative center of the Tyumen region of Russia, and located in the Tura River. And we are stay near the 3,000 kilometers east from the Moscow, in West Siberia. This is our center from above. This is a center only for neurosurgery. This center is only for neurosurgery. All service inside is only for neurosurgery. From 2011. Our first operation was in
John, you should maximize. You should maximize the presentation. Albert, you should maximize the presentation.
Okay. It's okay?
Sometimes it's a little difficult. Sometimes it's a little difficult.
Okay, okay.
He might fall off if he does it.
Okay, okay. Our center work only six year, and we start from 2011. And from this time, we do more than 20,000 cases. And the most idea is minimally invasive neurosurgery in our center. Our center have a very good equipment. And you see we have now 7 operation rooms. Like you see in the picture, this is a typical operation room and for the spine surgery. This is, and I want to congratulate Dr. Ayep and Dr. Juha Karnisemi because he also realized the dream of the world neurosurgery and established new, very well recognizable center in the Nepal. My congratulations, Ayep, for you. We have also a good team for the diagnostic, like all kinds of MRI possibilities you see in the. Also, the PET also possible to our center also. And the structure include 95 beds, and our center include 5 departments. These 5 departments cover all 5 of neurosurgery. So why we have a department for the child? This is pediatric department. We have department cerebrovascular department. We have the spine department. We have neuro-oncology department, and we have functional department and the vascular department. Of course, we have ICU and so on. Our center is very busy, and more than near the 4,000 cases we will do per year. So 20-30 cases per day. So it's possible to see our departments do more than 500 oncological cases, more than 600 vascular, more than 1,000 spine, more than 600 functional cases, and pediatric cases is more than 500 cases per year. So it's very busy department, very busy center. Center have all requirements for the international recognizable residency program possibilities.
Albert, you're still on the first slide. Do you still want to be on the first slide? There you go. Okay, okay, you got it. Okay.
Okay.
It's okay now.
Okay now. Okay, I am a supervisor of residency program, and my field of interest is что-то ниже. Полностью, понятно. Она полностью не входит. Она мне не видно, что. One moment.
Okay, Tech Branch of Medicine. It's okay, folks. We're just getting used to this tech.
And for this short period, it's okay now.
Okay, Albert, just you have to click on the slide on the left column. Each slide you have to click on. Each, if you want to go to 3, you click on 3 on the left column. There you go. Click on the individual slide you want to show. That's it. There you go. Hands-on teaching technologies. Oop, you made it the screen smaller. There you go. Okay, it's good. Is your audio okay? Can you hear me, Albert?
Moment, sorry.
Okay, we can't hear you.
So we start only 2011, and from this short time of period, our Federal Center of Neurosurgery was world recognizable for Asian Congress of Neurosurgery and double FNS neurosurgical societies. So more than 700 doctors from 25 countries have experience about technology in neurosurgery, high-level technology in neurosurgery in our Federal Center of Neurosurgery. And in this slide, possible to see some places which doctors come to our Federal Center of Neurosurgery for training. Можно на другой слайд?
Albert, are you there?
Yeah, moment, we here.
Okay.
Moment.
You're on the slide with the map.
Yeah. We try now. Technical problem now. Момент.
Здесь надо остановиться.
Okay, you're off. You're off the screen share now. Okay, you're on the screen share now. This is new tech. You guys just learned it this morning. There you go. That's it. Click each slide individually. That'll change it. Whoop. Slipped off. Be patient, folks. It's the first time learning screen sharing. And they were good enough to step in. Chandra Deopujari, a neurosurgeon from India, was sick. Okay, that's excellent. That's excellent, like you have it now. Perfect. Just like I was saying, full screen. Yeah, that's perfect. Okay. Now, if we just get your audio, can you hear me, Albert? And Russia, can you hear okay? It would be great if we could just hear the audio. Okay, now we're getting the audio. Now we just need to get the slides.
Do you see now?
Yeah, we see you, but we don't see the slides. You have to go back on the screen share.
Just a second.
Okay, no problem. We can edit this out. We can edit all this out. 90.
Now?
There you go. Yes, we do. Excellent.
Excellent, yes. Do you see
Yes,
our
yes,
screen?
Yes, we can see it now. Yes, excellent.
Presentation is a full screen.
Right, that's very good.
Moment. Okay, now it's possible in this slide. It's possible to see how many, what in which place from the world the people come to our Federal Center of Neurosurgery to have some training in endoscopic surgery, on skull-based surgery, epilepsy surgery, for example, vascular surgery, for example. It says from Brazil, a lot of people come from Pakistan, from, of course, of Russia, Germany, Great Britain, Switzerland, France, and so on. And we have a very good international team, includes the IAP, and I hope Professor Hernesiemi also in the future to have the training in our place for the young residents for international training. We have a good cooperation, good relation with some professional and scientific community, like the WFNS, for example, ACNS, ENS, VANS, and Association of Neurosurgeons of Russia, and so on. You see in this slide. For a residency program, we have some innovative technologies for education. Some innovative technology for education. And this innovative technology includes some parts. First part is the hands-on teaching technologies. And the second part, highest part is 3D live surgery. And in hands-ons include some laboratories for this purpose. First level is simulation laboratory. And for this kind of training, we use some models and simulators for developing skills in artificial models. Another level, second level, is the cadaver lab. This cadaver lab we use for the anatomical studies and develop skills for making microsurgical endoscopic approach in hands-on training. And the next level is full body cadaver lab. It's a new cadaver lab in our place. We create this cadaver lab in last year only, but it's a very important laboratory for us and for training. Also, we include some possibilities for anatomical studies, endoscopic and microsurgical approach, and especially in spine, peripheral nerve, and vascular system. And the second level is a vet lab, veterinary lab. It's for have skills for mainly for microsurgical anastomosis in some animals, and mainly in the rats, Laboratory for artificial models and simulators includes we have some 3D prints, and we print some models to have some experience for drilling, for example, and it's possible to see in this slide. Okay. For example, we see the example of some temporal bone. What we print in print, and we use like a model for dissect and for drilling modeling before the cadaver lab, for example. Another place is another silicone model of the spine just for study anatomy. Also, we have very nice 3D and 2D photo and video laboratory also to prepare some pictures, photos for the scientific purpose and for writing for writing the papers and writing the books, chapters, and so on. Special laboratory. In this slide, it's possible to see some kind of specimens what our residents prepare for science, for education, for hands-on training programs, and so on. You see some specimens for the Klinger dissection examples. You see the Klinger dissection examples for the white fiber tract dissection courses and so on. This is specimens what create my residents during these courses. You see the sagittal place of the brain, for example. Some interpeduncular sister anatomy. This is a step-by-step brain-wide matter dissection specimens. And next step is the cadaver lab. For this purpose, we create a very nice place for education. And this place open for our residents during 24 hours, completely free, completely open, completely friendly. And you see every place has a special table, same like operation table, and with all possibility for operation table, with air, for example, compression, the water, and so on. And then have a special big screen, 3D screen. And in this screen, it's possible to see the our instruction dissection, for example, live surgery, and for example, dissection for the people who want to training, participants. So like this, we have 11 places in our cadaver lab, you see. You see, every place has the good microscope, have good drills, have a good endoscopic system, and have good visualization system. And then all dissection in our cadaver lab we do by 3D camera. You see the 3D camera. This is the place for instructor, and all this 3D image we share to our participants. And this is some examples of some courses what we will do, what we was do last years. For example, it's skull-based surgery in 2016. For example, Professor Luis Borba is our main guest, and Vinka Dolens, and other guests like Aib, Keki Turel, and Roy Daniel, and so on. This is an example of our workshop with epilepsy hands-on. And you see how we do in this in our lab. With some cadaver specimens, the participants use microscope. And our main principle is education is collaboration, teamwork. And in our place, one team as participants, neurosurgeon and operation nurses work together. You see the operation nurse and neurosurgeon as participants work together and learn together. It's another examples of the courses. For example, you see some courses like again practical brain anatomy courses. For example, you see the Evandro de Oliveira and Kadri Ugetura, Musi, and other important, very famous people, neurosurgeons from the world, work with us as guests. You see the examples of our courses. This is epilepsy courses, for example, and also very important is our operation rooms have all equipments for the 3D online transmission of the data from microscope to this conference room. and the participants sit down on the conference room and take the glasses and see the operations in 3D. It's very important, in 3D. And it's possible to discuss by surgeons about cases and about the operations and so on. Also very important, this is big honor for us, is using neurosurgical TV to share our knowledge about the world. And thank you, Ayep and Dr. Bennett, for these possibilities. Thank you very much. Also very important.
Very good, Albert.
Okay.
You're going to continue, correct?
Okay, and another very important tools what we have 3D video archive. More than 20,000 surgeries now it's possible to study in some separate possibilities of neurosurgery. For example, possible to study some kind of posterior transtemporal approach, for example, some anterior Petrosa, and so on. Also, we prepare some channel on the YouTube, and it's possible to see our operations, our technique in YouTube also. The next level is full body cadaver lab. You see, this full body cadaver lab have also possibilities for full body. We use some C-arm and so on. This is an example of this one of the cadaver workshop. Last year we do some courses about the CV Junction, craniovertebral junction surgery, and we have a good team also, Professor Salman Sharif and Nikolai Peev and Erti and so on. This is an example of the working in this full body cadaver with span, and another is another highest level is the wet lab, veterinary laboratory, where our residents and our participants work with the rats, and mainly we use some microsurgical improved some microsurgical skills, mainly anastomosis. Live surgery. Live surgery we do in these operation rooms. What you see in this slide. This is our typical operation room. And in this slide, you see some past educational events, navigation technologies, endoscopic transforaminal, spine, microvascular, endoscopic, and so on, skull base, epilepsy. And in this slide, it's possible to see our plan for the next 2018. And we have also, we plan also near the 20 workshops, and we invite all young residents to take part in these skull base and others workshops. It's possible, and we have information in our website. And you see the practically all find of neurosurgery possible to study in our place. Also microvascular anastomosis, some spine cases, spine courses, vascular courses, skull base, and for example, facial nerve surgery and so on. And in this year we have new idea. We divide our skull base courses into the two parts. First part is standard approach, like a pterianal, for example, and others approach, and second part is advanced courses in October for a real skull base surgeon, for example. And what technologies we use in our federal center? One of the most interesting is skull base surgery. We have a lot of experience. And you see how we trained our residents. Our residents must know a lot of knowledge, for example, anatomy of the skull, anatomy of the muscles, some landmarks, for example. And with purpose we use drill systems. We have some main type of drill system like a Codman, Escolab, Medtronic, and so on, and a lot of bars and also we use very interesting system like a Sonopet, and the Sonopet is very interesting because it's not dangerous, because no rotation moments. You see how it's work, and we use it in very important, like remove the anterior clinoid process or jugular process from transcondylar approach, for example. You see the using our helmet, for example. Also another very interesting device. You see I work like a boxer. My hand is completely free. Every time I am in focus and in zoom. Some examples of the surgery before, big tumor, CP angle. Okay, maybe, I don't know, we have time, not have time for a lot of video.
We have time. We have time.
Okay. Okay, this is example of our skull-base surgery, for example, with mastectomy, open middle ear, incus. Now open facial nerve. This is sigmoid sinus. This is middle fossa temporal dura. Tip of mastoid here. This is facial nerve. You see very well. Facial nerve, facial nerve. Now I do under the facial nerve. This is sigmoid sinus. Sigmoid sinus. Now we remove the bone also. More. Or drill completely. Where is labyrinth? I want to see. Okay, remove the bone. Now I open the labyrinth. This is translab approach. Okay, this is after operation. Total removal. Post-op, just immediately after operation. This is 6 months after operation. Vascular surgery. Also, we have every year more than 600 cases. Endovascular and open surgery. It is the half between the endovascular and the open. And you see some example of giant fusiform aneurysm. Giant aneurysm. This is some example of the surgery. Open. Remove the thrombosis mass. Remove the aneurysm sac. Anastomosis. And just two. This is anastomosis. Doppler. After operation, control. Another case is a giant aneurysm. This is bypass surgery. The example of the bypass surgery. You see the bypass. First and second after operation. Endoscopic surgery is also many important part in our center, because sometimes it's need to really minimally invasive surgery for tumors, because patients come to our hospital in very severe condition, or for example, for a small baby, it's also very important, really minimally invasive surgery. So why we use endoscopic tumor surgery sometimes. And we see the equipment for endoscopic surgery. For example, oh, sorry. This is we prepare this operation room for the for biportal approach. For biportal approach, you see the two endoscopic kit, two endoscope, and this is operation room for biportal endoscopic approach for tumor removing, for example. This is typical general view of our operation room for endoscopic surgery. This is the screen, the endoscope, and the position of the surgeons, and you see must be very comfortable. Eyes and monitor in one level, for example. This is equipment for the endoscopic surgery. You see the Mitaka, for example, holding. And so on. Some navigation system. Mainly we use brain-up navigation system, but we have other kind also like Medtronic, like Sonovan, for example. This is an example of the really pure endoscopic surgery. You see the big tumor inside of the posterior part of the third ventricle. And also this is a very small baby, only 3 months, so open surgery is very difficult because dangerous for blood losing. So why we decide to do endoscopic minimally really invasive surgery. For this kind of approach, we use transfontanel endoscopic approach to the lateral ventricle first and go from the foramen of Monro, go inside of the third ventricle. And the first step is create the ETV to restore the CSF circulation. And this is the ETV steps. And this is another step, the dilatation of the Fogarty balloon catheter. And we go inside and see, this is, you see the basilar artery, pons, and next step is the removing of the tumor. You see the tumor. Oh. Okay. Sorry. Sorry. You see, we remove now tumor endoscopic, and you see we use bimanual dissection for this kind of surgery, like in microsurgery. You see the bimanual dissection. It's very important, bimanual dissection, endoscopic surgery. And we see we remove completely tumor. This is after removing the tumor, we check the space, no bleeding, no hemorrhage. All structure is okay, no problem, not destroyed. This is after operation, completely total endoscopic removal of the tumor without craniectomy, only through the one bar hole. This is the second days after operation. You see only small incision, maybe some 5-6 millimeter only. And for next day, this baby discharged from the hospital. Also, we use some kind of multiportal approach. Some difficult cases, we use multiportal approach. You see? Multiportal and navigated endoscopic system. You see the navigation, we navigated sheet of the endoscope, and this is multiportal approach. You see, we use two endoscope system. This is the case of the multiportal approach. You see the big tumor, also very vascularized. So why we use small baby, so why we use biportal approach. And we see the peduncle of the tumors. A lot of big vessels.
So why we decide to introduce second port. This is the introduction of the second port inside of the ventricle, lateral ventricle. You see the second introduction of the second port. This is a view from the first endoscope. When we coagulate and crypt the peduncle of the tumors, clipped, and cut by scissors and remove the tumor completely total. Pure endoscopic remove from biportal approach without create the big hole. And this is after operation. You see, completely total remove the tumor, no tumor, only 2 bar hole. 5 days after 5 days after operation, this baby discharged to home from hospital. This is colloid cyst also. We have also a lot of experience of colloid surgery, endoscopic surgery. Okay, I think maybe next. This is after operation. Completely total removing from 1 bar hole. Endoscopic, another case is endoscopic surgery of cranial synostosis. This is standard typical approach. You see the cutting of from ear to ear, very traumatic approach. So why it's possible operate only old boys. We don't have limit of the age for this kind of surgery because we use endoscopic surgery. And you see our incision is only 1 to 2 centimeters. And this is endoscopic operations, you see. So we don't have limit for the age. And for us possible operate from 1 day to 1 month newborns, no problem. With excellent results. And our residents also teach this technique also. Epilepsy surgery also another kind of surgery what we developed very strongly in our center. And also our residents have possibility to teach this technique. All kinds of surgery, epilepsy surgery we have in our federal center. You see the resections, some cortical, temporal, frontal, and so on. Disconnection surgery, functional hemispherectomy, callosotomy, and also neuromodulations technique also possible. Before we implant some electrodes in any part of the brain, epidurally, subdurally, deep brain of deep place of the brain, without any limits. You see the kind of electrodes inside, for example, before surgery. So we first electrodes and then localize the focus, and then we remove this focus, pathology focus. This is an example of the introduction of the electrodes for the deep place for invasive EEG. With this purpose, we use stereotaxis systems. This is an example of the implantation of the subdural electrodes. Also, we have a good experience with the functional hemispherectomy. Now we have more than 30 cases. This is an example of this kind of surgery. You see the flight of the brain, you see the atrophy of the brain, hemisphere. And this is some example of the surgery. At first, we do perinsular approach. Open the ventricle. Remove the amygdala. When we do fornicotomy, and when we do callosotomy, this is a Monroe, for example, and we do callosotomy. You see the callosotomy. This is after operation. And this is a... что там проскакивает, ну ладно. This is after operation. No more deficit, like before surgery. Like before surgery. Post-op, very good results, no seizures. And some kind of this disconnection also possible. Some parieto-occipital disconnection, for example, and so on. Also, this is some another example of the surgery. This is Sturge-Weber's, for example. You see, like it, how many lot of vessels during the approach. You see, all this is all vessels. Not easy surgery. Must do very careful microsurgical dissection to save the vessels. It's the most important to save the vessels, vascular supply of hemisphere during this kind of surgery. It's very important. Mapping for disconnection and disconnect parietal lobe and occipital. This is after operation. Also, seizure disappear. So some example of the selective cortical resection. You see the deep brain stimulation also possible in our place, and we have lot of experience in this kind of surgery. This is another example of the really minimally invasive treatment of epilepsy, and you see the hamartoma in the bottom of the third ventricle. And standard technologies include the big surgeries with open of the third ventricle, and it's very difficult to the patient after operation. So why we use for this kind of surgery really minimally invasive technique, endoscopic technique. We create only small bar hole, and we, through this bar hole, we put endoscope inside of the lateral ventricle and from the Monroe to the third ventricle, and now we start to disconnect this hamartoma from the wall of the third ventricle. You see, this is the third ventricle, this is hamartoma, and this is the disconnection of the hamartoma from the wall of the third ventricle. And in this case, we not only disconnect, we also completely remove this tumor. Totally, completely remove this tumor, piece by piece. You see, this is a piece of the hamartoma, and this we remove it. Endoscopic, pure endoscopic, through the one bar hole. You see the mammillary body. You see the mammillary body. You see the completely total removing of the tumor. This is before operation, you see, and this is after operation. Total pure endoscopic, really minimal invasive surgery. Seizure disappear. This is another example of the really minimal invasive surgery. This is endoscopic callosotomy with posterior and anterior commissurotomy. This is total callosotomy. Also through the one bar hole. It's really minimally invasive. Only one bar hole. We put endoscope inside. You see the anterior commissure, and we cut with anterior commissure. At first, this is monoforamen. This is choroid plexus. This is third ventricle. This is columnar fornicis, and this is anterior commissure. And now we cut the anterior commissure. You see the anterior cutting anterior commissure, and now we start to create the callosotomy from inside. This is the technology, endoscopic technology from inside. We open the callosa from inside, just to go inside of interhemispheric fissure, and to find the callosal artery. You see the artery? So now it's callosotomy is completely full. And now we only follow by these vessels, by this coagulation device. And it depends what we want now. Completely full, not completely full, only part of the callosa. It depends from the clinical case. Again, this surgery we do through one bar hole only. It's really minimally invasive. You see, this interhemispheric fissure with the vessels inside. After operation. Another very interesting tool is hybrid CT operation room. Also very useful tools, especially for tumor surgery, for vascular surgery, for functional surgery, for spine surgery, and so on. CT with high resolution CT on the rails during the operation. And this connect in automatic registration regime with the navigation system. In this case, we have BrainLab Pure navigation system and with the microscope size. So all these tools, also ultrasound, connect in one automatically registered system. This is very important. Some examples of surgery with ICT. And it's possible to do all possibilities during surgery. ICT perfusion, for example, if you do bypass surgery, to estimate the function of bypass. And this is the example of using ICT. For example, with fibrosodysplasia, we check the limit of the resection of the bone. Three-D endoscopic neurosurgery. It's another very optimistic technology in the world neurosurgery, not only in microsurgery, but also in endoscopic surgery. So why we have this kind of surgery in our place also. You see the stereo vision technology. This is the equipment what we use in this kind of surgery. And this is example of the surgery. With the glass, we do operation with 3D in 3D. This is a 3D visualization for microsurgery. So this is some short list of our technologies what we use in high-level neurosurgery for our residency study in his residency program. And in this slide you see the international center, our friends in residency programs, and we have some international exchange programs for residents. And I hope also now we have exchange program with you and with your center. This is last event. We have some lectures in Cape Town, and you see how it's far from our centers. Completely all world we cross. This is Cape Town. And I hope, with good of hope, and we hope to collaboration. The length is not important. Friendships important. And with some people who want a residency program or some fellowship program in our place, in this slide you have some contacts, some telephones, and some emails to organize this kind of residency program. Thank you for your attention.
Okay, Dr. Sufianov, thank you very much for a comprehensive overview of what's going on in Tyumen. And let me see if Ipe is still here. Ipe, are you still there? And you know, I can see why Dr. Sufianov, why it's an inspiration for Ipe to start his center, right, Ipe?
Yeah, I know. It was because of Sufianov, and I was inspired by his center and by him to start this here. And you should go see this place. It's one of the best places in the world, I'm sure. I've been around to a lot of places in the world, but in no place has something been started from scratch like this. And Sufianov's, Albert's interest in neurosurgery, in each of these branches, he calls people from skull base, from epilepsy, for fiber dissection, for everything. He calls people, and he keeps on doing these courses, and that too, all courses of the most sublime quality. So I'd like to, do the same here, but I must say that I was very inspired from Sufianov and his center and his team of musketeers. May not be three, but his team who is very, very supportive for him. It's a dream team, so it's a center which I think the whole lot of you from Europe or United States or anywhere should be going and seeing, and things are moving from west to east right now. So that's what I think. Instead of going to many other places, we should go to these kind of places and see what's happening.
Well, I can say that hopefully we'll use neurosurgical TV to collaborate between Nepal and between Tyumen, as well as to other neurosurgical teaching centers in the world. Of course, we'll follow your direction, but I think it's a good technology to communicate with centers like what Albert has to what's going on in both places, an interaction of information. So any comments from the panel? Margarita, Dr. Jumo, Rakesh, or Slaven? Any comments or questions for Dr. Sufianov?
I have a question, if you can hear me well like this. From the perspective of us younger people on the panel, what are the requirements to get into residency at your center, for example? We can talk in these terms. I mean, what do you require from a young graduate to accomplish in order to enter the residency at such center as yours?
I do not understand.
Thank you.
Did you hear the question, Albert?
Not understand correctly.
Yes. What are the requirements?
Question.
I'm sorry. What are the requirements to enter the residency at your institution?
Did you hear, Albert? What are the requirements for your residency program?
Requirements.
Yeah.
So in the spring, you must send me some your CV, and we start to work with the people who want to become a residents in my center.
Okay, you have the contact.
You have my mail. Send me CV with contact, and then we start to contact and.
Okay, let me put that.
Because our the program starts from September, so before September we must recognize all your requirements and our requirements.
Yes, thank you. I was interested in this, and also this question applies for Dr. Cherian, perhaps too, if he can comment. What are the requirements for Biratnagar and his center? I'm just asking this because I have many inquiries from young medical doctors and graduating students about this.
So it's difficult. So we start from your CV. Send me CV, and then we communicate. Okay.
Okay.
Thank you very much.
Main important, we must start in spring. We must start in spring because our residency program starts from September. So before September.
Okay, thank you. Maybe if you can
Must
type
okay.
Your email would be helpful for this.
Yeah, at the end there, you had a page. Well, we'll publicize that page.
Okay, perfect. Thank you.
Okay,
Thank you very much.
and I'll let you know. While you guys are talking, I'll put it up right now, matter of fact. Okay, let me see if I can put it up here. Just give me a second. Any more questions or comments from the panel while we're waiting for me to put this up?
I had. Hello.
Yes,
Hello?
Go ahead.
Yeah, I had similar question like Slaven questions, but I would just like to congratulate Professor Sofianov. This is one of the best center I've ever seen myself. I have to be honest. I think it's a must go. It's a must see place. Unfortunately, I've not seen an African residence there, but hopefully, because of the reputation you have, you might get some. Really impressed. Really nice place to go. If you are interested in neurosurgery, I think this is the best place to go. And I had similar questions like what Sofianov, what Slaven have asked, but I was asking which language do you use for teaching? Is it English? Is it Russian? Which language do you use, and how long does it take?
Oh, in my place, no problem. English language is enough. English. So our staff know English, so even operation sisters, so no problem with English.
Sure.
Okay.
I know.
Okay, I'm just punching it
So
up.
it depends what kind of you want, a fellowship or residency program, some short duration. So
as for me,
yeah.
As for me, medical fellowship, but I know I might be asked by some who are interested in doing neurosurgery, and I would really recommend this center. So
Okay,
I was interested to know for someone.
You must spread the knowledge about our center during the Africa, no problem.
Okay, there we go, Albert. There's the contact info. Can you guys see that okay? Can you see that contact info okay? Okay, you can copy it down, and I'll certainly have access to it, Jumo and Slaven. We'll give you the contact info for Albert and the center. You got that? Okay, I'll get off there. I can always give it to you later. So, when did you start that, Albert? How long ago did you start this center? About 15, 20 years ago?
Yeah, we started 2011.
2011.
2011, first operation, 2011, yeah. But
Okay.
every year, 4,000 cases every year. So it's a lot of cases for training, for study some technologies. It's enough.
Now, there's another center similar to that in Russia?
Oh, we have main important center is the Burdenko Institute in Moscow. Another is Polenov Institute in St. Petersburg, and another is same center like me in Novosibirsk.
Novosibirsk. Now, do you communicate with those centers?
Four main center.
How many?
4 main center in Russia.
4 main ones. Do you communicate with those other?
Center in Russia. Yeah.
Do you communicate with those other centers?
But in my center, I have a lot of attention to high technology neurosurgery.
Oh, okay.
This is very important for really minimally invasive neurosurgery, for example.
Okay.
I pay attention for this kind of technology.
Okay, so if someone wants to learn state-of-the-art neurosurgery in Russia, they go to your center? Do you communicate with the other centers at all, or do you kind of operate on your own?
What again?
Do you communicate with the other centers in Russia, the neurosurgery education centers?
Of course, we contact. So I don't pay attention. But if you see my presentation more precisely, you must see what now I organize chair of neurosurgery distantly, because now we organize chair of neurosurgery in Moscow, in First Medical University, and now I am chair of and I am chairman of chair of neurosurgery in Moscow.
Okay.
With, First Medical University, and our residency program. We have the papers from the first Medical University from Moscow, not from Tyumen.
Oh,
for
okay.
example. So we have good collaboration with Moscow's educational program, and now all documents the people receive. The residency program is from Moscow.
Okay.
From First Medical University. Officially.
Okay.
Officially.
Okay, well, we offer you the use of Neurosurgical TV if you'd like to communicate with those centers and to have conferences. I don't know if you do that now already, but we could do that if you'd like, but we can talk about that later.
Okay.
Okay, okay, very good. I appreciate the time you took, Albert, and we hope you're a regular part of Neurosurgical TV and give presentations from Tyumen on cases, on what's going on.
Okay, thank you.
Whatever you want to communicate, whatever you want to communicate, just let us know. And with IPE and UHA, we'll form a good team, I think.
Yeah, it's big honor for us. And again, thank you very much for invitation. Thank you very much.
Okay, very good. Okay.
Thank you.
Okay, thank you everybody for participating. Have a great day from Neurosurgical TV.